via life.
A very good evening to one and all of you for yet another very interesting ARC webinar, a video bouquet of learning more in cataract surgeries. And with the kind of speakers we have here, with their very interesting videos and a great set of expert panel, I'm sure we can look forward to a next very arresting 2.5 hours. We have joining us soon on the expert panel, Dr. Debashish Datta, who is a senior consultant cataract and cornea services from Disha Eye Hospital, Calcutta. Joining us very soon would be Dr. Suin Bhattacharya from 9 Eye Care, Calcutta, and who's again a very prolific surgeon. He is already joining us. Joining with us, joined us is Dr. Sai Kumar, is a medical superintendent and head of cataract and glaucoma services from Giridhar Eye Institute, Kochi. Again, a very dynamic surgeon. We really look forward to learning a lot from him today. We are truly lucky to have with us our ever popular Dr. Minu Mathan, who's a senior consultant cataract and refractive services from Chaitanya Eye Hospital, Trivandrum, who has contributed massively to our ARC webinars. And joining us soon is Dr. Arundhati Borat, who's a chairperson, scientific committee of the Ophthalmological Society of Assam and a senior consultant of LASIK Laser Eye Care Center at Guwahati. And with me is this very dynamic Satyajit Sinha, who's the chairman and medical director of ABI Institute based at Patna. He's a cataract, refractive, and glaucoma surgeon, and also member ARC East, and is a very dynamic national figure. I'm sure most of you would have seen him at different points of time, and has been contributing very significantly to our ARC programs. We start off with the first speaker, Dr. Archana Vare. Dr. Archana Vare is the senior consultant at Arogyam Eye Clinic and Laser Center, Mumbai, and she has a very interesting video for us to see. On to you, Dr. Archana.
Good evening, everyone. So today I'll be speaking about the SICS in iris coloboma. Ma'am, is my screen visible?
Yes.
Okay. So this was a patient who had, this was a 46-year-old patient and male patient with total coloboma. And so decided to do SICS surgery in this patient because this patient had a black cataract. So basic demographic characteristics, preoperative corrected distance visual acuity, intraocular pressure, along with detailed ocular examination was done for this patient. And the patient underwent anterior as well as posterior segment examination. And the patient had a typical iris coloboma with grade 3 chorioretinal coloboma, sparing the macula, according to Edelman's classification. The patient had a hard cataract, almost grade 6 nuclear sclerosis, according to the lens opacity classification system 3. The nuclear color was black, and the IOL power was calculated by immersion technique with SRK-T formula. So decided to do this SICS because of the black cataract. Otherwise, the corneal diameter was normal. So after doing the initial tunnel or the initial incision, then I did stained the capsule with trypan blue, and then I did a rhexis. The rhexis imposes a problem in colobomas because many patients have zonular instability or there is zonular loss in some clock hours. But fortunately, my patient did not have any zonular instability, and the corneal diameter was also normal, and the pupil was also well dilated. Then I did the rhexis for this patient, and after doing the rhexis was also not a problem. It went uneventful. It was uneventful. And then I opened the anterior chamber, and after little hydrodissection and hydrodelineation. I delivered the nucleus, but the nucleus was rocky hard, as you can see now. It was a black nucleus, and that's why I decided to do SICS basically. Otherwise, with such good corneal diameter and well-dilated pupil and stable zonules, I usually prefer to do a phacoemulsification surgery. Then I delivered the nucleus. You can see the black nucleus, and then there was a chorioretinal coloboma behind. And then the remaining cortex was aspirated. And then the IOL was implanted in the back. So the presence of microcornea or non-dilating pupils, absence of zonules or lens coloboma, and the other structural anomalies make cataract surgery more challenging, and they are fraught with complications in these eyes. This patient was like, under surgery was uneventful. And the patient did well in the post-operative period also.
I'll call you after this. Okay, after 8:30, I'll call you. Okay.
And patients with coloboma, they develop cataract at a much earlier age as compared to normal population, and they tend to have harder cataracts as compared to the normal population. So this was my post-operative. And that's all. Ma'am, you are mute, ma'am.
These are very challenging cases, and you have shown the whole surgery very elegantly. But going on to just elaborating a little more, Dr. Minu, would you tell us, do you have any kind of a cutoff when in a colobomatous eye, you would want in a brunism cataract, when you take a call to do a phaco, and when would you take a call to do an SICS?
Just today, 2 hours back, I saw one 49-year-old lady with this kind of 2/60 and hand movements in one eye with the choroidal coloboma previously noted. One eye was black, and the other eye was, she didn't have microcornea. We measured. So other eye had a grade 3 to 4 nucleus. So if it is microcornea, and if the nucleus is 3 to 4 towards black color, I would not do a phaco on that, especially when you do not see the lower part of the zonules. Mostly they'll have coloboma there also. In this patient, the black cataract did not have zonules, maybe larger area, actually not just the coloboma area, beyond that also did not have zonules. So it will be difficult for me to do phaco in such kind of black cataract. But till grade 3, and if the pupil we can always manage. You can dilate it with the high-risk hooks and all. So till grade 3, I would do phaco if the microcornea and the chamber is not too very shallow. I would do phaco. But otherwise, if it is too black, and if the cornea is microcornea and pupil is pupil, okay, anyway, we can do stretch it with the hooks and then do the rexus and then prolapse in SICS also. So that will be my cutoff. If I'm not comfortable doing, if I think that I'll get a zonal dialysis and a PCNN, I would do SICS with a large, not an SICS, I will call it an LICS. It will be a large incision, sutureless, even sutured also. Even if you make a corneal incision, it's better to suture off, put 2 or 3 sutures for such cases, and do a clean SICS in that cases.
But did you see that the trypan blue staining of the vitreous was there?
So I was about to tell that, but I didn't want to comment on the case because I was answering your question.
Yeah.
If you ask me to comment on the case, then all these will come up.
So that means there was some amount of minimal zonular weakness is there in this. That was there. So
yeah, because it will be there, it will be seen.
Dr. Sai, I want to ask you, what would you be cautious about in these kind of eyes, colobomatous eyes, and if there is zonular weakness, would you do anything extra, or would you be cautious of anything extra?
First of all, I think I should
You should increase your volume. Yes, Dr. Sai?
Can you hear me now?
No, it's become very low.
Can you hear me?
On the laptop, can you increase your volume?
Usually Sai is very loud.
Yeah, now it's fine. Yeah. Yeah.
So I think I should congratulate Dr. Archana for bringing up this case here, because this is in cataract surgery where there's a lot of unpredictability involved.
Mr. Sunil, his volume is very low.
Dr. Sai, on the Zoom window, next to the mute, there is a small arrow. Just click that. In audio settings, the bottom link. Just increase your microphone volume to maximum.
Did you get it?
Next to the mute, there is a small arrow. Click on it. Audio settings, bottom last option. Click on it. It will give a pop-up on the microphone. Just increase your maximum volume to the maximum.
It's already maximum.
It shouldn't have automatically adjust option, should be unchecked.
Yeah. Sai, just talk close to your mic.
Yeah, now it is better, sir.
No, that is not. That is me. That is not Sai.
Oh, sorry.
Yes.
Okay, Dr. Sai, let's have your thought.
Start coming up.
So you can log out once and come back again. That works sometimes.
Okay, in the
Sai,
interim, while Dr. Sai gets his volume increased, Dr. Suven, would you want to comment on this? What question I asked?
Yeah. So two things I'm very particular about is I don't want the vitreous to be stained with trypan blue. It not only is messy on the table, and it leaves the patient with a lot of discomfort also later sometimes. So I would plug that collaboration. There invariably there is no doubt that the zonules are deficient in that area inferiorly. So I would like to plug that area with the high molecular viscoelastic to start with before I put the trypan blue. That's something I'll do. And rest, I think I'll agree fully with Meenu that I would rather do a SICS large incision cataract surgery. And if somebody is not comfortable doing SICS or LICS, I'd rather do an extracapsular cataract extraction in a very hard cataract.
There's also this logic about putting a CTR in these eyes, because besides taking care of that imagined zonular weakness, it also could be a little preventive measure for a fluid misdirection from occurring. Because it stretches the capsular bag. So the fluid misdirection could be a huge challenge, because many of these patients, by the time they come, they have a very hard cataract. A hard cataract and a hard eye can be a huge challenge. So that was one factor which I wanted you all to bring up.
Can you hear me now?
Yes, wonderfully.
Yeah.
Wonderful. Any thoughts to this before we?
Yeah, no. Before I just was to saying that I should congratulate Dr. Archana for bringing up this case, because this is one of the things in cataract surgery where there's a lot of unpredictability involved.
Yes.
Each case is different. There is no one formula for every coloboma. It depends on whether the zonules are totally absent. What is the amount of lens zonule weakness you have? Sometimes at the area of the zonule of the weak lens, the rexus may run off. So we usually have alternate things with us. And of late, I had 3 cases in a row where there was rexus is intact, but while trying to do cortical aspiration, the whole bag came out. And I don't know whether any one of you have done this, but I have done 3 cases in a row with iris claw.
Yeah.
With inferior. The inferior part is open, but then these patients are used to that inferior part loss anyway. They don't complain of any visual problems because of that. So
Yes.
I have done even iris claw for 2-3 patients in a row. So these are conditions where you can have right from a simple phaco with maybe plus or minus a CTR with a routine IOL bag implantation up to what Dr. Archana showed, a routine SICS with the interbag implantation. And in the other extreme, you can have, total loss of, zonules and you may have to think of alternate techniques. And microcornea obviously is a big problem. The smaller the eye, the bigger the challenge.
Yeah. The other question is, what are your thoughts about sandwiching the nucleus and the way she brought it out, or would you think of bisecting it, or is just a different technique which each person is comfortable with? Any of you, Dr. Meenu, you want to say anything?
Yeah, I think we should use a technique which you are comfortable with. So if you're
Yeah.
not using regularly the sandwiching, I would not suggest in such a huge nucleus into the AC 2 more instruments and pull it out. If she was delivering it with visco, so no vectors also. So larger the incision, you can easily deliver your own way. So that should be the point. The incision should not be tight. It should be loose enough to bring out any nucleus without touching the endothelium. One point which I wanted to make is when you're injecting trypan blue in these kind of cases or in subluxations, I would rather put sodium hyaluronate on top of the capsule, put a little saline on top of the capsule, and then drop the blue drop by drop on the capsule and paint it. So that we need to go 5.5 millimeters and need not splash the whole anterior chamber with the trypan blue. And also aim if you're putting under saline or under air bubble, don't aim it towards the lower 6 o'clock location. Aim it upwards so that it doesn't get injected directly into the area of zonular dialysis.
Was it Dr. Siddharth? Somebody who raised his hand wanted to add something. Anybody in the speakers want to add anything? We go on to our next talk.
Yes, madam. I am Dr. Ramlal Sharma.
Ramlal, yes, Ramlal.
Yes. As a rule, I'll say in most of these cases with coloboma, the non-phaco surgery is preferable due to various reasons that was pointed out by different experts. So the phaco will be exception, keeping in all the small. Sometimes the nucleus is pigmented and hard, and even the delivery and the emulsification is really difficult in the small cornea, invariably granular deficiency and smaller eye, and that will be my comment.
Thank you. Thank you, Dr. Archana. That was a wonderful presentation. We go on to our next speaker, Dr. Ambika Shetty, who is a chief phaco and refractive surgeon from Gitanjali Eye and ENT Hospital, Trivandrum. Let's hear from Ambika. On to you.
A warm good evening to all of you. Is my screen visible?
Yes, visible. Yeah, start.
Okay. So thank you, Chitra ma'am, for the invite. It is really an honor to speak amidst all these experts in this webinar. Today, I will speak on a case of pseudo-exfoliation with dense cataract and a non-dilating pupil. So in the preoperative evaluation, I noticed that the patient had extensive pseudo-exfoliative material on the anterior capsule. As I was expecting zonular weakness in this case, I decided to use capsular hooks. So side ports and a clear corneal incision was made. When the capsule was punctured, I noticed that it was lax, but with frequent regrasping, I was able to complete the capsulorhexis gently. Once the capsulorhexis was completed, a gentle hydrodissection was done. Minimal rotation of the nucleus was done. 4 additional side ports were made and capsule hooks were placed. I also decided to make a 5th side port and put a 5th capsule hook over there. The nucleus was sculpted and debulked. The phaco tip was impaled into the core of the nucleus, and the nucleus was fragmented into 2 halves. It was a combination of a horizontal and a vertical chop to minimize stress on the zonules. The nucleus was further fragmented into smaller pieces. Once the fragmentation was complete, The pieces of the nucleus was emulsified in the pupillary plane and slightly away from the corneal endothelium. The residual cortex is removed by bimanual irrigation and aspiration. Tangential stripping of the cortex induces minimum stress to the zonules. I'm relieved to see the intact posterior capsule and bag after cortex aspiration and decide to proceed with the implantation of the intraocular lens. The lens is placed and the capsular hooks are removed. The viscoelastic is aspirated and the wound is hydrated. To summarize, proper preoperative evaluation is essential. Usage of appropriate intraoperative devices minimizes complication, and gentle surgical maneuvers reduces the stress on the zonules. Thank you.
Thank you, Ambika. The question to Dr. Sai. Dr. Sai, are you connected?
Yes, yes.
See, no, I think I'll take one question. Hello, Dr. Debashish. I'll ask him, sorry.
No problem, no problem.
Debashish, did you see this video now? So
yes, it was a wonderfully
so
done.
many
Satya.
capsular hooks. Don't you think we could have slipped in a CTR and played it safe, and that too, that kind of an obvious pseudo exfoliation? There has been some doubt over the stability that she put hooks. Wouldn't you have placed a CTR instead, because it will also take care of the fact that this is a progressive zonulopathy here?
Right.
Yeah.
One just as because this is a national forum and what she used was fantastically done, but what she used was not iris hooks, it was the Macul capsular hooks.
She said
These were
capsular
used.
hooks only.
Okay.
Yeah.
But it was used mainly for the iris, or you just stabilize the capsule also?
Stabilize the capsule.
Capsule.
Okay. CTR would have made things simpler and would have, I mean,
She need not have put
less-
so many side ports, She could have
Yes.
placed a CTR instead.
a
It's just
CTR somewhere between the in the middle of the phaco after removing one or two pieces, when
Yes.
there's enough space in the capsular bag, you could
Yeah.
have used a CTR. That would have made things simpler for you only and also for the patient.
Yes,
Thank you. And cohesive viscoelastics below the endothelium was a must.
yes.
I hope you must have used it.
Yes,
Yeah.
that I've used.
Yeah.
Actually, the cataract was very dense. So that
Yes.
is why I didn't use the CTR.
Yeah. No,
No,
you
that
have-
is again, madam. Can I again? It's a personal preference of when to use CTR and how comfortable you are. Initially, long back, I used to put CTRs much earlier, during surgery. But I have later on realized that that is not actually required in many of these cases to put a CTR early itself. We can easily manage these kind of generalized zonular weakness with, if you need capsule support, or most of the times without capsule support also, if you have done a good hydrodissection. And pupils, this kind of pupils are actually, they don't usually come down. So close to 5 millimeter pupils, I don't put pupil dilating devices also. But the crucial point is to have an adequate rhexis and not to chop off the rexus or cause zonodialysis while you're chopping underneath this mid-dilated pupil, and have a good nucleus rotation while that all she did well. And small paracentesis are all okay. Putting iris or capsule hooks according to her comfort level, I think should be left to the person's surgeon's discretion, which will she be comfortable.
No. If it's a traumatic zonular weakness, I wouldn't have suggested a CTR, because it is a pseudo exfoliation and she felt some instability, imagined it. Not every hard cataract, she saw that pseudo exfoliative material, and that's what made her use capsule hooks. So why
but a
not?
CTR will not help in a progressive zonulopathy. CTR is not going to help in reducing it. It will only keep it stretched for some time and later help you in fixing the bag with the CTR. That is the only use of a CTR in a progressive zonulopathy.
Would you use a little larger rexus, Dr. Sai, for these cases?
Yeah, as large as possible, and covering the areas of the pseudo exfoliation capsule.
Yeah.
So I think I would have probably done the same procedure as far as the zonule weakness is concerned, because I was not very sure I made out the amount of donuses intraoperatively. As Minu said, if it is very minimal or not at all, I wouldn't have used any device. But if I need to use a device, I would definitely go in for a capsule hook. And at the end of surgery, then I will decide whether I should put in a CTR or not. So as we all know, earlier every pseudo exfoliation we used to put CTR 5 years, 10 years back. But now many of them are coming back with the entire CTR bag complex, moving here and there, dislocating and things like that. So those are issues that has to be kept in mind. Yeah. But I would have done the same procedure if there were significant donuses. I also use the capsule hooks and not the intraoperative CTR.
Would you believe there is a role for anterior lens capsule polishing in this pseudo exfoliative cataract, Dr. Sugan?
No.
No.
Answering your question, no, I won't believe. In fact, I don't, except in very young patients, I rarely ever do anterior capsular rim polishing because when she can remove the lens cells and they reduce the chances of PCO and other capsular fibrosis and other things. But coming back to the use of capsular hooks or...
My thought for ALC was there is a tendency for phimosis to occur in these cases. The CTR actually keeps the bag stretched and less phimosis. A little larger rexus again, a little preventive to phimosis. So in that context, I wondered whether anybody considers capsule polishing.
I would rather have a large generous capsular rexus than use a CTR to prevent phimosis. That is because a CTR in a progressive zonular loss is not achieving anything.
Yeah.
Unless you're using a Sioni ring, which is sutured, we are not achieving anything. If you're really going to prevent the bag from dropping down. But a question to Dr. Ambika is, what was the reason for you using a capsular hook? Because we didn't see any donesis at all.
It's a hard cataract. So
that's not a good enough indication.
No.
That is not a good... because you are crowding, I would rather suggest that you use iris hooks and keep the pupil wide, make a generous capsular rexus, and then you have more visibility. You see what things are happening. Because just to use, you could have actually damaged that capsular rexus. In such a hard cataract, you put a capsular hook over there. The amount of movement that is happening over there, you could probably damage that capsular rexus. So I would rather recommend that you use iris hooks, keep the people widely dilated so you can have a generous capsular rexus, and then go ahead and assess as it goes by. And yes, of course, you delay the using of the CTR. If you do see enough movement over there, we use hooks, and then we delay whether we want to use a CTR or a Sioni ring at a later stage during the surgery, depending upon what we finally assess as the zonular strength availability.
Thank you. I think we need
one small point is
speakers.
One small point is I make nowadays, if the zonules are really weak and when I aspirate the cortex, you see that the bag is coming and you see the zonules, I make 4 or 5 small cuts on the rexus margin at the end of the procedure. Excellent. That again helps very much in reducing the phimosis. Phimosis is the point. It's a problem.
Yes, 100%. Wonderful point. Good, we had these discussions. We go on to our next speaker. Thanks a lot, Ambika. Wonderful video it was. We go on to our next speaker, Dr. Hemalata Gudiseva, who's the Director of Cornea and Refractive Services from Shankar Netralaya Chikitsalaya, Vijayawada. And she's going to show us her case. On to you.
So, good evening, everyone. Is my video visible?
Yeah.
So, this is a case of phacoemulsification in a patient with post-keratoplasty. So, this patient is actually one-eyed patient. By starting surgery, the incision was planned.
Doctor, please pause.
Music.
Can you just stop the
A lot
sound?
of music coming in.
The music is coming, but it is overshadowing everything else. Can you just mute the video?
You mute the video and talk, Hemalata. There's only noise.
On the bottom, the speaker, this thing, just mute that. Bottom, नीचे जो speaker का left, right, हाँ इसके साथ में, just mute that.
Or at least decrease the volume. We can't hear what you're trying to say.
Yeah. Okay.
Yeah.
So this patient had usually the challenges we face with these kind of patients is tough observation, because of the graft post junction scarring, and there are also many synechiae, posterior synechiae or peripheral synechiae, and sometimes there can be unstable chamber. But though this patient had a lot of synechiae, both posterior and synechiae at the graft post junction, but he had a very good dilated pupil. And the grade of the cataract is slightly between NS1 to 2. But because he is one-eyed, so I had to do cataract surgery for this patient. And because this lens is softer, so I plan to do a slightly bigger rhexis. Hydrodissection is done routinely. I prefer to do a stop and chop, especially in these patients which has a slightly softer cataract. And other challenges in these patients is IOL power calculation. So we did with the help of IOL Master 700, and we took Barrett's universal formula, and we compared with SRKT formula. Both almost came similar. So after dividing the nucleus, these nuclear pieces were emulsified under the plane of the iris, and care was taken that the chamber is stable throughout the entire procedure, and the nuclear pieces, care was taken so that the nuclear pieces don't touch the corneal endothelium. So cortex wash is done. So I prefer to do a non-toric foldable lens in these patients because this is a full thickness keratoplasty, and keeping in view future graft rejection and failure. Though this patient had around minus 6.5 cylindrical power, so I did not place a toric lens. So the lens is dialed into the back. Again, under the visco, I tried to remove some of the synechiae at the graft host junction, but I was successful only to remove 80% of those synechiae. So the rest of the synechiae, I kept them because there can be chances of iridodialysis, and this can make the problem more. So after that thorough visco wash was done, So instead of doing the hydration, I put a tunnel suture so that there is no hydration at the graft host junction, over hydration. So this is a pre-op and post-op pictures. So on day 1, and this is the pre-op topo picture. You can see there is -6 cylinder at 40 degrees, and patient in the post-operative period improved to 6.9 with -2 cylinder at 40 degrees. So that was my case. Thank you very much, madam, for giving me this opportunity.
That was a nice case. Although in a soft cataract, you need not, unless you're going to do a carousel technique or a flip, you need not have made a larger excess. But the other important thing I wanted to ask you was, you could have done the synechiolisis after the cataract surgery, because you had to do it all around. Unless I would have thought of doing a synechiolisis, the AC is so shallow that I can't even get my phaco probe in because it's so shallow. But otherwise, this was a deep, I saw that when you took your phaco probe in, the AC was quite deep. So what is your, I'm not sure whether there's any other cornea person. Dr. Arundhati. Yes, Dr. Arundhati, are you there? We needed a cornea opinion about this. Would you think she could have considered doing a synechiolisis after doing the cataract surgery? Or would you have also done it prior?
I think I would have done it prior only. I think it's a beautifully done case. I should congratulate her, and again, as every speaker has said previously, I think it depends on your comfort level. Though the AC was deep, then midway, you don't want any crisis. So whatever is doable actually beforehand, it's better she did it. And I think I would have done the same.
She said another very wonderful thing, that a toric IOL, these corneas can go in for rejection. So
Yes.
it makes no sense to put a toric IOL.
No,
in
it
those
doesn't.
eyes.
We usually don't in these kind of
So then what justifies that 6 diopter of astigmatism dropping down to 2 diopter of astigmatism is an interesting thought.
Yes.
Anybody can think, and what could you have thought of it? It just came up to my mind. I hadn't noticed, unless Hemlata has something to add herself about this. I mean, you have not put a toric IOL in this eye. So the removing of the lens, there was more of a lenticular astigmatism in this eye, or what? Which
no,
could,
topo showed, topo itself showed 5 or 6. No, sometimes patients don't
The
accept so much.
6.5 cylinder.
yeah.
Sometimes it's just that the patient don't accept. Can I add 2-3 points on?
Yes,
Can
yes.
I add?
Yes.
So
yes.
I would generally go cut the conjunctiva, go a little limbal or a slightly scleral incision for such kind of cases, because invariably I'll end up making the entry at the optic at the graft host junction, and that will be. So I usually do that and put a suture to that also without hydrating too much. And many times when you put a paracentesis, comfort is another point. We have to put it somewhere where comfortable. At that point, there may be total synechy. You may have to pierce through the iris and go in. So that also doesn't actually matter, making a 1 millimeter paracentesis. A large rexis in this one, I would not have done because it is not needed, because a smaller one would have covered the optic very well and prevented PCO and all those later. And this one was quite old, is it not? The graft was done quite many years back.
Many years
so
back.
Thinking of a rare possibility of this getting decompensated and then the toric IOL going bad, I would definitely have gone for a toric IOL and corrected what was there now. And later on, if the cornea goes bad, then everything goes bad. Then it becomes more again a regraft and a new cylinder coming up and all those. Anyway, you'll have to correct it. So that is my choice. And the BSS, I would have definitely used BSS plus for this, and a lot of viscoat initially from the beginning itself, because the irrigation itself, in turbulent irrigation itself, can be damaging to endothelium. And so the endothelium should be coated with the viscoat from the beginning till the end of the surgery. And we need to take precautions to take out all the this one also. And if you don't want to put a toric option, another option is to do a pinhole pupilloplasty. But for that, you need to release all the synechy well, and then the iris should be free and all those. That is for there. A pinhole pupilloplasty is also a possibility. Otherwise, very well done. Corneal
Yeah.
endothelial protection is the cardinal point where she was doing it quite well inside the bag and not bringing it out, and slow and steady, but not too slow to irrigate too much and waste a lot of time in the anterior chamber. Irrigate least and the reduce turbulence to the maximum, reduce the turbulence.
Yeah, wonderful points. And actually, Hemlata, your case was good. This talking about toric and bringing up these things, is not finding fault. It's just that I want to energize the expert panel to come with 1, 2, 3, 4 points like was happened now. So
Yes, ma'am.
very nicely done surgery. It was so clear that your phaco parameters were very optimal and the surgery was below the iris plane. So then we go on to our Dr. Jebin could join us soon. He's on a flight. So we go on to Dr. Madhu Duraj, who heads the cornea and refractive services from Sri Karan Institute of Ophthalmology, Kakinada. And he's going to show us his case. Again, another challenging case, well managed.
We have no financial disclosures. A 63-year-old elderly lady was referred to us after small incision cataract surgery, was abandoned, suspecting a complete Descemet's membrane detachment while entering into the anterior chamber. Due to poor visibility, the patient was referred for a combined procedure of cataract extraction and IOL implantation along with endothelial keratoplasty. This is the clinical picture showing diffuse corneal edema with evident Descemet membrane detachment on anterior segment OCT, which looks pretty bad. The case was taken up for surgery and we tried identifying the Descemet membrane with trypan blue staining and eventually identified an area of focal loss of Descemet membrane. The anterior capsule was also torn in that particular area with some lens material spilling into the anterior chamber. Illumination from external light source was also used to aid in better visualization. We created a capsular opening from that area and managed to complete a capsular excess. The cataractus lens was soggy and was further dissected and delineated with controlled hydro procedures. Phacoemulsification was then performed specifically in the area of focal Descemet membrane loss using a combination of chip and flip with flip and chop technique with optimal parameters of 380 vacuum and 35% power using Venturi phaco machine. The procedure was supported with external illumination by scrub nurse whenever needed. Care was taken not to engage the remnant Descemet membrane fraps into the phaco probe by holding them with a blunt dialer. The phacoemulsification was done with controlled pace, cracking the nucleus small piece at a time. Cortex aspiration was done using a Simcoe cannula. IOL was implanted into the bag. The Descemet membrane is visualized again with external illumination and with trypan blue staining. The Descemet membrane was then reattached using air and a few venting incisions to aid better tamponade. Post-operatively, the Descemet membrane attached well as evident on anterior segment OCT. After 6 weeks, the patient's vision improved to 20/40 with spectacles and with regular post-operative medications. Staining of Descemet membrane with trypan blue and external illumination play a vital role in managing cases with compromised corneal clarity. Surgical tips from this particular case are to use the area of Descemet membrane loss as working area for phacoemulsification. Use optical phaco parameters and choose a technique like flip and chop, which is appropriate for this particular condition. We have avoided SICS in this case as we felt that the Descemet membrane would be further damaged with prolapsing the entire nucleus into the AC. Thank you.
Again, a very nice video shown by you, Dr. Madhu. That was very nice. But I have different thoughts and questions, so let's go at it. Dr. Devashish, you are there? Dr. Devashish? Yes. So I thought I'll ask you this particular case. I feel that this kind of a case with a DM tone and a larger area, it's not a planar DM detachment. I would have felt better with a long-standing tamponade like C3F8 than just an air bubble. And the second thing is, I wouldn't have thought of giving a venting incision, because unless there is some obvious indication that there is fluid or viscoelastic or something which is separating the DM, I think venting incisions is not being done too often, right? So your thoughts on that. But of course, she did want, the result was wonderful, but I just want thoughts for this.
The results are wonderful, but this is not a very predictable situation. It depends on how this air bubble would tamponade and where you inject the air bubble, visibility with the trypan blue and the visibility through the opaque cornea. These are all variable stances. In this particular case, she was lucky enough to do it that way. But if we have access to this on-table OCT, or the operating microscope, it has got an OCT, this would make life simpler. Otherwise, this oblique illumination will help, and the trypan blue will help to a certain extent. But it all depends how much of Descemet's membrane is remaining.
No, it was seen on AIOS OCT. There was Descemet's tear, large area of Descemet's gone. And I don't know whether an air did very well here, but probably a C3F8 gas would have been better. Dr. Arundhati, you have anything to tell?
I think I agree with you. I think she's been beautifully done surgery, and she's just lucky that everything fell into the right place, because visibility was an issue, and with the trypan blue and all that, it's commendable she got through the whole surgery. And yes, to be on the safer side, I would have used a C3F8 or something. But then, and again, the question is, how long was it? Like, the referred to you the same day of surgery, that failed SICS, she said, elsewhere. Like, if it's a fresh case, then okay, you may get away with air. But then if it's been referred and has lost 1 or 2 days, I would have been much more comfortable with C3F8,
Because the tears would get more fibrosed and will not unfurl well.
Yeah.
So that's the challenge. But if a C3F8 gas, would you think of doing a PI on the table to prevent a pupillary block kind of a situation? I mean, I'm just asking. I want
this kind of a visibility PY, it would be very difficult.
Can I reply, ma'am, to the
place
question?
Of air injection is most important, where you inject the air bubble. Air bubble can be given a try if you don't have C3F8 at hand.
Yeah. Yes, Dr. Madhu?
Yes, ma'am. It was referred to us almost immediately. The case was done within 24 hours. We operated again. That is one point. And regarding C3F8, if you see, when we do routinely this DMEC surgeries and all, we don't use C3F8 at all. And the clue I have taken was from an article where, like, even hemi-DMEC we are doing with half of the DM scroll. So I thought if we are able to manage like that, we can prevent an endothelial keratoplasty. That was the whole idea, to give it a try. Even I was not sure whether the DM was going to reattach with such a bad folding kind of an ASOCT picture. So that is the reason we tried ASOS, the AIP that we use routinely. And that is one reason, ma'am. And venting incisions, as you have rightly pointed out, I also never give them too often. But in this particular case, there was a lot of use of visco continuously and all. So I was skeptical that some visco might have gone into the interface. So just I wanted to make sure that anything is there. I wanted to milk it out. That was the reason I gave, ma'am.
And for a long-acting tamponade, what are the thoughts of doing a surgical PI on the table, an inferior PI?
Yeah, actually, ma'am, regarding the tamponade, I follow Samarbha-Sixer's principle. Whatever attachment happens in the first 20 minutes, 80% of it. Yes. So I make the patient in the sleeping position with full air fill. Then I release it to 70% and then send him.
Yeah.
That attachment, whatever happens on the table.
Yes.
Can I talk one second? This case is Madhu. Madhu, this is yours.
Yes, sir.
No?
Yes, sir.
Everybody has been calling you she.
Yeah,
It is
my
not she.
fellow's
It is
voice.
Madhu. Okay, fine. Sound was only fine.
So, Madhu, you should only give a voiceover.
Yes.
My only question is: this is the only incision was done, no? While referring to you, capsulotomy was not done, is it not?
No, sir. Actually, what happened? If you see superiorly, there is a scleral wound.
That's what I understand. But then capsulotomy was not done, no? Before.
No,
before
They had just opened the capsule, no?
She have opened the DM and also
Okay.
opened that with the same force. She was thinking she was not able to complete the rexis. It was done by a PG in a.
Okay,
elsewhere.
fine. But then capsule was not open.
It was open.
It
sir.
was open.
Capsule was open.
Yeah, because she tried hard.
Contact was there.
She mistook the DM for capsule, sir. That was the problem.
Okay.
She went
But it
into
was
the
actually
DM game.
very, very lucky for you to have the DM still on till the till the end of surgery. But
Dr.
then,
Madhu, can I ask you a question?
Sai, one point is he is happy because he doesn't care. See, DM goes or not, he has experience in replacing the DM and doing DMEC very easily. We are scared, we don't, we let it refer to somebody else. He has his own hands, he'll easily replace. But then for me, I would have definitely be very, very scared to do a phaco at this point of time. And I would have, because definitely we'll have to put visco. So, and as he said, trapping a visco behind this one and not having a venting, then it would have been definitely a problem. So that is justifiable to have venting incisions because of visco. Because I've had a DM detachment with visco there and it would never attach. It would never attach unless you went or you release this one. So that is one thing. But then I am appreciating you very much, Madhu, for being so daring with this kind of DM hanging there and doing phaco. Wonderful.
Can I raise a controversial point here?
Yes.
If the visibility was slightly lesser than this, would you have considered a two-stage procedure?
I was about to tell that. That's why I asked.
Because with a better now that you have done phaco, you have got away with your rexes. You have not had any problem with nucleus management. Extremely good surgery, and to an extent, luck was on your side also.
Yes.
But at what stage would you have considered a two-stage procedure? Getting the things cleared up first and then handling the cataract? Or is it because the capsule was open, you didn't do that?
Yes, sir. Capsule was open, and also while usually this edema happens when we clear off the epithelium, dye it, and use this external illumination. With the visibility itself, sometimes we can guess, sir. If it is very poor and not able to visualize, I would have definitely thought of just removing it an SACS and later do a DSEC or DMEC. I just gave it a try, sir. My whole idea was to avoid a transplant if possible.
Yeah, that is true. But what his question is if you put air for a day and wait for a day to see whether this is going to clear much better by a better attachment, and then your cornea is going to be much clearer for a next day procedure. That was your question, Sai.
Yes.
Clear the cornea first, try whatever you have to clear the cornea first, and then surgical visibility and visualization during the procedure is better.
Yeah.
Sir, but again, with such a bad DM detachment, there is always a risk of the DM detaching again when you go in with this.
Exactly.
That is possible.
This is a tear, not a detachment.
The capsule was already open.
It was torn.
Yeah. Excellent.
Thanks a lot, Madhu. Wonderful
Thank
case.
you. Thank you.
We go on to our next speaker, Dr. Nilesh Kanjani, who's a director and head of Vitreoretina department at Dr. Agarwal Eye Hospital, Bangalore. On to you, Dr.
Thank
Nilesh.
you very much, madam. Yeah, my video is seen, madam.
Yes.
Okay, this was one of the interesting cases which we had, wherein 32-year-old patient who came with the injury of reflect ball, and here you can see Leslie was also the biggest case. You can see a nice epithelial growth, vomiting vitreosis, subluxated lens with the zonular weakness, because secondary to the
I think volume can be reduced, no?
Okay, now I think it is better.
Thank you.
So in this, the posterior segment, the view was also a little bit hazy. So we're not able to clear what is going on behind. So we went for a B scan. We can see a classical retinal detachment in this case. So it's a kind of a major case wherein we go with the first step. The first step was to do a safe remove, do a anterior capsular axis. And you can see that the cellular weakness is also there. So we are putting a CTR ring. So once it has to be done very carefully, you can see I'm trying to put it gradually. Okay, and we can see a significant cellular weakness in these areas. Now, all these cases has to be done. This is the most important step. You can see that dye which had almost gone behind came in front. So anyway, we are planning vitrectomy in this case. So once this portion is over, so once the CTR ring is placed, viscoelastic was placed, and we place intraocular lens in it. Preferable intraocular lens in this case because it's a double loop lens and probably it's a quite wide one, and it went easily in the bag. So once this portion is over, we plan for the 3-port pars plana vitrectomy. So once the lens is in the place, we waited for some time to make sure it is stable. You can see here, we went for a pars plana vitrectomy. We are able to see the giant retinal tear. So things coming up slowly, more and more things are adding up in this case. So once the went for thorough vitrectomy, and at the end, you can see the laser, we injected silicone oil in the same case. So far, so good. At the end, we also did the scleral buckling as a part of the procedure because usually trauma cases, we do scleral buckle. Now, what is the next step? Next step is we have to remove, suture the traumatic mydriasis with the 4-throw pupilloplasty. We do the 10-0 Prolene where you can see the 180 degrees, 2 scleral ports are there. Once this stage is over, pupilloplasty is over. So next is the anterior segment cully coming into picture. We try to lift the flap, and there is the flap is very thin. It's quite old. Surgery was done many years back, and we are trying to remove the epithelial ingrowth. Since the flap is thin, the movement has to be very steady, quite simple. Try to remove as much as possible gently, and make sure that we are not trying to disturb the flap too much. So once the epithelial ingrowth, you can see slowly just moving towards the periphery. We try to lift it till the edge of the flap. And once we do it, we try to remove all the epithelial ingrowth, which is there here. So probably it seems that things are much better now. But only thing is that once we try to clean the flap, there's one more thing which was left out, which was a free flap. Yes, we could have marked the cornea and then tried it. So once the cornea is placed once again, then we suture all the ends, and probably we inject air in the anterior segment. And this is the case. And this patient we are following up, patient has almost improved very well to 624 vision because there are a lot of atrophic patches on the macula. Thank you very much, madam.
Yeah, one amazing video. Like the whole ophthalmology was shown in this particular case. Thank you. But there are some questions here. Why would you want to put a scleral buckle if you have done an endo laser also has been done at the end of vitrectomy? Is question 1. The question 2 is, there is zonular weakness. The silicone oil is likely to come into the anterior chamber. So that possibility again is there. So when that all is there, so could you have at least done a PI? Would that help? Does it make sense? And why did you need to manage the corneal condition? It was an epithelial ingrowth. It was there was not aggressive stromal melt happening, and that it's already an inflamed eye, operated eye, so many surgeries done. Could the epithelial ingrowth have been taken care even a month after? I mean, these are the 3 questions I have. I would want maybe the expert panel could answer it, or you could answer it.
Madam, as far as the scleral buckle is concerned, in majority trauma cases, we do scleral buckling many cases, just as to prevent recurrent retinal detachment, or let's say to reduce the PVR. And as far as silicone oil is concerned, the eye, let's say, the retina was not looking that healthy. So silicone oil was placed in these cases because scleral buckle and silicone oil both were done, and silicone oil was later on removed at, let's say, 2.5 months. So anterior migration of the silicone oil probably would not have happened. Very rare cases it would happen. And as far as PI is concerned, the pupilloplasty when we did, there was a partial small PI which was already there on the table. Now the vision was a main factor because it was lying in the central visual axis.
Yes.
So vision was 3/60. Even if I would have done a very good retina surgery and anterior segment surgery, still the vision was a main concern for the patient. So by removing the epithelial ingrowth, patient vision, what is there, 624, which we recovered post-operatively, the patient recovered. I would not be able to give the same vision to the patient with epithelial ingrowth because quite significant in the visual X-ray.
Yeah, but very thin flap, epithelial ingrowth, there has been some kind of a stromal melt here. So you would want a more ideal situation of a very nice quiet eye before we do it. Dr. Arundhati, would you want to add anything about the cornea part of it? And I leave the other expert panel to give their thoughts. Dr. Sai, would you want to say anything? Dr. Meenu?
Yeah, I can talk about the cataract part. And the subluxated cataract is repeating the same thing which we talked about in the first case. In zonular weakness, if you are identifying zonular weakness, either plug that area off with the dispersive viscoelastic and then do staining of the anterior capsule controlled under cohesive viscoelastic to paint the anterior capsule, because you could see that there was no glow. No glow, maybe because of retinal detachment or the blue going underneath. So blue going behind makes it totally dark, and it is very difficult to do if it is a hard cataract. This is a soft one, but that's okay. But then still, it is difficult to operate, and it can be totally avoided rather than injecting. See, under the iris and all, is no need to go under the iris. Small pupils nowadays, I do not go under the iris and stain. I always retract the pupil, put sodium hyaluronate and retract and then stain on the anterior capsule only by putting drop by drop. This is a very important point which I keep in mind in all these small pupils and in areas of subluxation. Otherwise, the rest of the cataract was fine for cataract.
What did you say in a small pupil? You would put sodium hyaluronate?
I would I have seen people putting in 3 millimeter pupil. Just so you can always put blue under the iris and then do I retract the pupil, make it at least 5.5 millimeter. So for retracting, you need viscoelastic. So either if people are putting HPMC, it has to be completely aspirated. It doesn't usually get completely aspirated. It sticks here and there on the anterior capsule. So I put sodium hyaluronate, which can easily be even aspirated, or even without aspirating, we can inject a little bit of saline underneath the visco on top of the capsule, and you get a plane of fluid there. So there you can easily drop it in the stain controlled way.
The only problem there is that you have to, retract the iris first before you do this, isn't it?
Yes, in a small people, 100% retract and then only.
So there's one small subset of small pupils which are the uveitic eyes, where you just put in some air and put a very, very minimal amount of trypan blue under the iris, and then by using Kuglen hooks, you can just stretch it and they remain like that. In such situations, too much of use of iris hooks will, damage the iris even further, and it gets torn here and there. So that is the only situation where I would, put trypan blue under the iris, and then use Kuglen hooks to do a stretch pupilloplasty. So it remains mid-dilated. Other than that, I think what Minu's point is well taken.
Suven's ring, it has now become no financial interest, but it has now become more than 90% of the cases of small people. I only put rings now. Hooks are very rarely put in very intumescent, very shallow chambers, and when they wanted a little more dilatation, I put hooks. Otherwise, I put this, and it doesn't damage the sphincter too much. Only the last one, when you put in, if you want to stretch a little bit, it may tear a little. That's all. Otherwise, it doesn't damage the pupil very much, and it remains very nicely round. So, and thanks for creating such a wonderful gadget.
I have another one of the cases to show you all, where you wonder about that. There are one odd case where iris hooks serve better. Again, open to discussion when we come to that particular case. I think that case comes now, I think. Thank you very much, Doctor. It was a wonderful combination of cases. Dr. Nilesh, you showed. Thank you very much. We go on to our, Arundhati did not comment on the cornea issue, which I said.
I think I'm quite okay with what he did, treating it, at the same time. Yeah, at the same time. Yes, I'm okay. Because you get really tempted to finish off all the things.
All of the things at once. Yeah.
And it was quite bad epithelial growth.
Yeah. Dr. Satyajit, I want you to raise your hand and ask questions whenever you want.
Yes, ma'am. Yes, ma'am.
Yeah. We go on to our next case, Dr. Nilesh Kumar, who's a consultant at Lotus Eye Hospital and Institute, senior consultant, and he is going to be showing a small pupil situation.
Thank you so much, ma'am. One small correction. I have now started working at my own setup. It's
Yes.
Madhvi Netralaya.
Madhvi
So,
Netralaya, where is that?
Yes, ma'am. In Bihar, ma'am.
Oh, very nice.
And thank you so much, ma'am, for this opportunity. I'll just share my screen. Sorry.
He is one of our brightest stars in Bihar. He's winning gold medals everywhere.
Wow. Oh. Congratulations, Dr. Nilesh.
Thank you so much, ma'am. My ring flows somehow this time. Sorry. So yeah.
So we have a 60-year-old eye with small eccentric pupil and white cataract. What should we do?
What happened, Dr. Nilesh? You shared earlier.
Nilesh to mute pe.
Dr. Nilesh,
Yes, ma'am. I'll just try again now.
Yeah, fine.
So we have got a 60-year-old eye with small eccentric pupil and white cataract. What should we do? Shall we use intracameral adrenaline? Shall we do stretch pupiloplasty?
Can you increase the volume?
Should we do sphincterectomy? Shall we use iris hooks? Or my favorite, BX ring? Let's see how the surgery proceeds. So we make the side ports and the main incision, and then the first thing we do is inject intracameral adrenaline, but it has no effect. Then we stain the capsule using the trypan blow by going below the pupil margin and then wash with BSS. Then we inject viscoelastic that goes below the pupil margin, below the pupillary plane to elevate it from the capsular bag so that the BX ring goes pretty well inside. The first flange goes directly below the pupil margin. The second flange is then engaged into the pupillary margin. But when we start engaging the third flange, you see the iris is being pulled towards the main wound, and that can lead to iridiolysis. So what we do? We use crutch forceps to do a stretch pupiloplasty so that we have some space to engage the third flange. So now the third flange is being pulled and then negotiated to place it below the pupillary margin, and now we have the BX ring in place. So now we inject BSS again and start with capsulotomy. Just as we relax, we see the capsular excess forceps engages the third flange and dislodges the BX ring. Now what should we do? We start again. We inject the viscoelastic, disengage the entire BX ring, and then renegotiate it below the pupillary margin, keeping in mind that the flange do not engage the capsular margin so that we don't have a torn capsular bag. So now the BX ring is again repositioned, and now we start with our routine phaco. So we do a hydrodissection, the nucleus is rotated, and then we proceed with a mix of vertical and peripheral chop. So we divide the nucleus into two parts from both ends, and then we take out the heminucleus and emulsify it, and then rotate and take out the second heminucleus, and then the epinuclear cleaning starts. So everything has to be done in the central safe zone, as that is the area visible, and we should try to avoid and go beyond the pupillary margin. Now this is something I learned from my father, to hydrate the main wound so that we don't have an iris prolapse when we start cortical cleaning under high flow. But when you're in the flow of the surgery, sometimes you tend to forget what you are taught. So in the flow, I just go from the main wound to disengage the cortex, and now when I enter again, I have an iris prolapse. but BX ring is there, so it is holding off most of the iris below, and I have only a minimal amount of iris prolapse, and that is quite helpful. So then I again reposition the iris, put in the visco, and then inject the IOL. But as the luck have it, I haven't flipped IOL. So then again, using Tosinski hook, I flipped the IOL back into the position and put it inside the bag. And now the time is to disengage the BX ring quite routine manner. Disengage one of the flange, then hold from one of the vertices and pull it out. So it's very simple to disengage it. And then I start with viscoelastic cleaning, minimal amount of iris prolapse because I was doing in the low flow now. And then I hydrate the main wound, and everything looks now that went well. The patient on the first POD was very happy, minimal amount of glare and a vision of 6/9. Thank you all for your time.
Yes, Nilesh, that was truly a wonderful video.
Thank you so much, ma'am.
It really talks volumes about your skill set. But then there were some issues about the BX in this particular case. So what would you want to add here, Dr. Sued? Does it mean that small pupil and shallow AC? That's one situation where you could consider iris hooks too?
Yes, the two situations where I would definitely consider iris hooks is one is a subluxated cataract. Shallow AC is not such a big deal. Subluxated cataract is a place where I always consider iris hooks because the ring is very thin. It's thinner than the hair. It's 75 microns in thickness, and using a 23 gauge forceps, which is 0.5 millimeter in dia. So it's 0.6 rather. So it doesn't make a difference over there. So if you have a 1 millimeter AC depth, that's good enough for a BX ring. And then you're going to inflate it anyway with a little bit of viscoelastic. As far as this case is concerned, congratulations, Nilesh. Very well done. Only thing I think there was a little bit of an assessment. What I recommend always is before we start off with the device, we need to assess whether it's a rigid pupil or an elastic pupil. So there, though you showed very elegantly how to manage it. So if you had an assessment that it is a rigid pupil in the beginning itself, you would have done a stretch pupilloplasty with 2 Kuglin hooks, and that would have given you a much more better cosmetic pupil. See, the circular shape of the pupil would have been there. Nevertheless, once you're stuck over there, once you've got 2 flanges in, this is the way to go. Or you'll have to disengage the ring again and do the stretch pupilloplasty and then re-engage the BX. So either way, I think it was pretty well done.
No, there is another way which I am doing it right now. Suvan, I've told you that also. See, when you have 2 paracentesis, when the first thing is to stretch it a little bit, because this iris, this is not the regular kind of small pupil. This iris is thin, atrophic kind of pupil and all those. So this has to be stretched a little bit, not too widely. It has to be just stretched so that you get few small sphincter tears here and there, so that it becomes slightly loose. And the third one, when you engage, use the one paracentesis to hold the ring, and from the second paracentesis, use a Kuglen's hook to retract. So you will need to stretch only halfway. One half the hook goes, the second half the ring goes. So you don't have to pull it drastically away. And the iris also, you don't have to retract too much.
Yeah, by manual technique.
By manual. That is the best way to tuck the iris onto the ring when the last one seems to be a little difficult. So rather than pushing it widely towards one corner, either with the forceps or with this one. So in this case also, the ideal one which I would use is the ring, because this is not a very shallow. My shallow chamber problem is with intumescent lenses. Intumescent cataract with very fluffy nucleus inside, and the very, very intumescent ones, I would definitely like to have a little larger kind of a pupil so that I am comfortable doing the rexus close to the pupillary margin. That is the only reason for a shallow AC. Otherwise, shallow AC is not an indication for me to use hooks. And here, definitely, this one was a good option. And engaging it during a rexus and all is a technique issue. That can be avoided by perfecting your technique while doing it. And iris prolapse, actually, rings do not prevent iris prolapse. So if you want to not have iris prolapse, have tight incisions and longer corneal incisions in the main incision, and don't let the paracentesis and all leak. So if you have leak, it will come up into the incision even if you have a ring there. So that is known.
In a very floppy iris, keeping the hooks I'm so for
Yes.
the hooks.
Yes, if it is a very floppy iris and if it keeps coming out, you better put a very small kind of incision longer into the cornea and try to avoid this. But otherwise, have your hook underneath or just next to your incision so that it can be pulled towards the periphery and avoid it from prolapse.
Dr. Chitra is so technologically advanced and still sticking to iris hooks. That's a little bit of a conflict over there. So anyway, coming back to what Minu said, I would yes agree with him, and I keep advocating this, that iris hooks or pupil rings do not prevent iris prolapse. The iris prolapse depends upon, like Minu said, is one is your incisions and second is the extent of the floppy iris. Floppy iris has different severities. So if it's a severe floppy iris, it's going to come out irrespective of what you try and do. Okay, so even if you have long incision, side incision, it is, after all, you're going to use some fluidics over there and do the surgery. So the extent of the floppiness of the iris, it may be a good day, a bad day. So how floppy the iris is makes a difference. What the ring or the hooks give you is a constant pupil size to finish the surgery. You must understand that.
Just one point, can I add?
Yeah. Yes. Devashish, I need your support.
No. The thing is, whatever ring you are using in a pupil which is rigid and which is very small, you need some minimum amount of stretch pupilloplasty to be done before you insert the rings. Shubhendra, do you agree to this?
Yeah, of course.
Exactly, of course.
You need it for even iris hooks, you need it.
Yes.
But for a floppy iris, you would not do a stretch pupilloplasty at all. I wouldn't advise triggering it off. At that point.
You see,
no, madam, not for floppy iris. Not for floppy iris.
See, a floppy iris is technically elastic pupil. Okay, so you don't need to stretch. We're talking of two different things. So a floppy iris, by definition, is an elastic pupil. But the question is, nothing prevents you from having a combination of different types of pupil. Okay, so in a floppy iris, you really the pupil which was 7 millimeters and has come down to 4. It was obviously, it had dilated to 7, so you don't need to stretch that. And if it's elastic, and you have a very simple test for doing that, is as soon as you've made your paracentesis, just inject a little bit of BSS or RL, whatever you're using from the side port. If the pupil expands a little bit, as the AC deepens, you know it's an elastic pupil. If it doesn't, it's a rigid pupil. So you go ahead. Now, how you choose to tear the pupil is your choice. Whether you're using 4 iris hooks, 2 Kuglen hooks, or a Malukin ring, or a APX, or a I-ring, or a BX. Now, BX is not strong enough to tear it, so I always recommend that you use a stretch. When I say stretch pupil, it does not mean limbus to limbus.
Yeah.
It just means make it about 5 millimeters. That's enough.
Yeah.
Exactly.
And regarding recurrent iris prolapse, at the site of the iris prolapse, if you put in, even if the ring is in place, if you can put in one iris hook below the incision site, you can allay the recurrent iris prolapse, which is annoying you so much in the surgery.
Yeah. And what about the role of using topical atropine pre-medication? Would you all of you advise that in a floppy iris situation?
What? Topical what?
Atropine.
Atropine drops.
Atropine.
No. I don't think atropine helps in any way in a floppy iris.
Yeah, when the IFACE was described initially, there was this feeling that pre-op atropine priming the iris for a few days would help. But I don't think anybody uses it now, and I also personally feel that it doesn't cause much of an effect.
Okay.
The use of dispersive viscoelastic like viscoat, no financial interest, is very, very important in IFACE. The moment, just like you were talking about recurrent iris prolapse through the wound, if you can just put in some viscoat at that area and push the iris away from your wound, it remains there for quite some time. 2-3 times you may have to reapply it, but it goes a long way in preventing recurrent iris prolapse. And like Suven said, the rings do not, prevent a prolapse. But one thing that definitely prevents recurrent prolapse through the main wound is one subincisional hook. So either you use 5 hooks, make one of them subincisional, and that definitely prevents iris prolapse.
Yeah, very good. That was a nice summary. We go on to our next speaker, Dr. Ramlal Sharma, who's a professor and head of ophthalmology from IGMC Simla. On to you, doctor.
Thank you, doctor. Am I audible, madam?
Yes.
Thank you very much for giving me the opportunity to present this case. This is not an unusual case, as we had seen all my previous speakers. This is a classical case of almost hypermature intumescent cataract, which I have certain points to make. You can see the incision I usually keep slightly posterior in such cases, because it is anticipated that there might be some complication, that is running away rhexis. I might lose the rhexis and ultimately may get some complications. So I tend to convert these cases directly into SICS, as this case is being done under topical anesthesia. You can see I usually start rhexis in such cases, as it tends to run away in the if I start inferiorly from the upper part, like envelope technique. It may not be that perfect, but usually it goes well, as I have two sides to make. If it goes away in one direction, then I tend to take it away from the other side. As the decompression of the lens starts, the chances of getting away rhexis is less. As you can see, I am likely to lose this rhexis. But somehow, if you depress this area, what I'm doing presently, the rhexis can be controlled, and you can still take it in and can ultimately complete this rhexis, as you can see. So that's one point which and another part is this one. As you can see, that this rhexis is slightly smaller, and the capsule, the lens is likely to be hard. So if I chop it, sometimes gets engaged into the rhexis. So I give 2 or 3 relaxing cut. It doesn't make any problem as far as the phacoemulsification is concerned. The another part is the hydrodissection. In such white cataract cases, it is usually the peripheral cortex is loose, and then it can be taken out easily with just hydrodissection, which I had done. And the next part is the phacoemulsification. As you can see, classically it will be a divide and chop technique, which in these cases I am most comfortable with. And usually the 2/3 or even the if you can go up to the 70% of depth of such nuclei, easily cracking is possible in these cases, and it usually cracks well. As you can see, hardly I had done 50% of the this thing gutter formation, and crack is almost complete. This is usually the point that I straightway go for the direct hemi nucleus to be chopped, and slightly it goes up. As you can see, it is the side port usually which leads to this sort of issue, that I am losing chamber in between. Some pressure always come from the side port, and this is how some of these issue rises in between, because I tend to go too fast. There is no editing of it in this video. This is a real-time video, and I usually tend to complete this part in 3.5 seconds. The next part is the intraocular insertion part. As you can see, the lens tends to flip while it is being pushed inside. I am likely to get it back by the time it is pushed back. And there's another part in volume surgery where we go too fast to push such situation, and ultimately this lens goes well. These are actually lenses from the Ayushman scheme, one of the cheapest IOL which comes under supply. So we don't have much choice in government institution to go for premium IOL. In some of these cases, people are from poor strata. They come late in a hypermature stage, and then we need to carry out with whatever means. All the viscoelastic and everything is of cheapest cost, that is packaged within 7,500 rupees, which the government scheme is. That completes my surgery. I usually do not do any hydration because my incision is slightly posterior. It never leaks, and that is the end of this surgery.
Yes, doctor, that was a fast surgery, and yes, You did very well too. But for sake of discussion, you stop sharing your presentation. There's a
Okay.
stop sharing. Yeah. I have a few questions, and these are all only for discussions. Each of
Yes,
your
ma'am.
videos this far, all of them have been so good. But it is just that yes, you started off making a larger axis, and but you did very well manage to get your axis down. And but then it is a clear-cut soft cataract. So why would you want to do relaxing cuts on a well-made capsular axis margin? And I believe the reason why you escaped not getting a rexis runoff is, I believe that when you make multiple nicks on the rexis, there are multiple weak points. So I think there's something about the vector forces which doesn't cause a rexis runoff to happen, because that's how you escaped in these kind of very intermittent cataract to unnecessarily make a nick on the capsule. I feel those multiple numbers saved you. And I want the opinion of everybody. And I think the third point is, I think your sleeve was very much retracted. Now, could
Yes,
that
yes.
have been the cause for your surge which happened in your case?
Yes,
Dr.
yes, ma'am.
Sai or Dr. Minu or Devashish, anything to comment here?
Agreed,
Shall I?
ma'am.
Sai, come.
No, I think the sleeve was a bit retracted, and the moment you move slightly towards the wound during your maneuvers, sometimes the AC can get shallower. This was, although it was a white cataract, it was one of those fragile white cataracts. It was not very hard. So you don't need a very long phaco tip to impale or crack them anyway. But otherwise, very well done surgery, and the way you manipulated the rexis and made sure it was a neat rexis was also very commendable. And I think sometimes it is our tendency to view everything from a very premier private hospital perspective, whether it is a phaco machine, whether it is the viscoelastics that we use, whether the intraocular lens that we use. But I think we should also give it to people who are working in government setups, in medical college, teaching hospitals, who do tremendous work. With whatever it's not that what you're doing or the equipments you're doing are inferior, but that feeling that only you can give high quality surgery only with this machine, that should change. So
No, 100%. I agree.
Yeah.
Actually,
so Dr.
I
Sharma,
wonder,
thank you very much for.
I actually wonder whether Sharma ever gets a rexis runoff, because the speed with which he does, actually on a femtocataract platform, it is said that if you keep the spot spacing in such a manner that the rexis happens in the minuscule time, you will not get any kind of rexis runoff there. So he does it very fast. But then we want our audience also to learn. So I want to bring up some of these critical points. I want controversy. I want discussion. Yes,
Yeah,
Doctor.
can I add few points? So if I put a scleral incision, I would nick on the sides of the conjunctiva to avoid ballooning of the regressing fluid through that. That's one point.
Yes.
Second thing is, I also have this, we get tempted to make an adequate rexis so that you don't have to do a double rexis. But I have now resisted that temptation 100%. And every intermittent cataract, I make a 2 millimeter, 2.5 millimeter small rexis first. After applying cohesive viscoelastics. Cohesive viscoelastics made by Indian companies are also very good, and they are cheap also. And they can be used. I think you all, in this case also, I saw an additional viscoelastic being placed on the anterior capsule to flatten the anterior capsule as much as possible. And then do a small rexis, aspirate the cortex from most of these clockovers, and then put again viscoelastic and cut it and make it a adequate rexis, so that you need not risk possibility of a runoff at any point of time. So at anybody's hands, this can be reproduced every other case. And the nucleus size we will be able to definitely assess once we take out the cortex. And this obviously look like a soft cataract, and side cuts I would not do. And even if it is slightly harder also, in such a 5 millimeter rexis is more than enough to chop it inside and finish off, because a lot of epinucleus and not epinucleus, the fluffy cortex goes out and the nucleus is much smaller inside the back capsular bag. And again, aspirating the cortex at the end of the situation, the retraction which happens, we have a tendency to go back. See, rather than moving back and forth and trying to catch the pieces on the sides, I also have this tendency of just go and catch it and finish off. So rather than that, I would now intentionally keep the phaco probe in the center and use our second hand, or swing the irrigation a little bit so that you pull the pieces which are little away from you towards the phaco tip by the irrigation flow itself. Otherwise, I would like to do all the rest of
You have these multiple nicks, no? You need to have very controlled phaco parameters. The kind of fast surgeon which you heard, that those nicks are weak points, is how I feel. So
multiple nicks, as you said, your point is the right point. As you make multiple nicks, you don't run a risk of extending it to the periphery. And again, the nucleus is small inside the bag. There is no stretch force which will be on the bag because of this 1/3 size, 2/3 size of the bag only is the nucleus. And so it will never cause any stretch force which can extend the erectus.
Intralenticular pressure gets released and out of the eye. So that evidence also run away. That was being done. I just wanted to stress on that point. So use ordinary visco, not even a cohesive or high molecular weight, but if you decompress it, prevention of the sudden decompression of the intralenticular pressure is the point. So as you do the rexus, you depress the posterior lip of the wound and make egress of the intracameral contents. That will decrease the pressure.
Anyway, Ramlal,
can I one point on that? I did not understand that very well. If the point is to reduce the intralenticular pressure by aspirating what is there inside the lens.
Inside the capsular bag.
If we depress on the posterior lip of the incision, you are going to shallow the chamber.
Yes.
So shallowing the chamber and along with that, taking out the cortex from inside the lens doesn't serve the purpose. The chamber has to remain stable, deep, and then aspirate only from the back. Using the cannula or the needle itself, we can pull. We can pull on the piston and it can be aspirated from the
anterior chamber. Those nicks and all can extend actually. You need
I wouldn't shallow the anterior chamber to get out the visco while the initiation is being done and it is made. I would reduce the this one by aspirating. It's very well possible by retracting just stop doing the nicking and then just retract the piston. You'll get that fluid running into your needle.
And multiple injections should be given. I mean, you should suck out the cortex from multiple areas. That should also be done. So wonderful. Anyway, we go on to our next speaker, Dr. Sandhya Nair, who's a senior consultant cataract services from the Giridhar Eye Institute, Kochi, and she has another amazing video to show us. On to you, Dr. Sandhya. You are very quiet, Sandhya. We didn't even know you were there. You should raise your hand. Come up with your points too.
Thank you, madam, for this opportunity. Can you hear me?
Yeah, yes. Can you start?
Yeah. Yes, madam. Thank you, madam, for this opportunity. This is a case of traumatic cataract with 3 to 5 clock hours of subluxation. There was no vitreous in the anterior chamber. A dispersive OVD was used to seal the area of subluxation, and capsulorhexis was initiated in the area of intact zonules. Now, in these situations, a microrhexis forceps will give better control over the rhexis. Leaving a rim of at least 2 mm will facilitate the placement of capsule hooks or CTR if need arises. Dispersive OVD was injected inside again to maintain the anterior chamber depth. Now, the clear corneal incision was made in the area of intact zonules. Now, a good hydrodissection is crucial to facilitate nucleus removal and cortex removal. Now, 2 capsule hooks are placed in the area of dialysis to give anteroposterior support to the capsular bag. And these paracenteses are made vertical and close to the limbus. You need not tighten the capsule hooks too much. Now the capsule hooks are placed. Now rotation of the nucleus should be avoided as far as possible. Now a small trench was made using adequate power to avoid stress on the zonules. Now the nucleus was further chopped into multiple small pieces. The rotation should be kept at a minimum level. And then these pieces as emulsified using low phaco parameters, that is low bottle height, flow rate, and vacuum. This is needed for maintaining the anterior chamber stability to avoid chamber fluctuations and shallowing. Now, before pulling the phaco probe, you need to fill the chamber with OVD to prevent sudden AC collapse. Now, the nuclear pieces are slowly being emulsified. Now, after emulsification of the nucleus, now again OVD is injected inside before taking out the phaco probe. The cortex is removed by pulling it tangentially rather than radially. Now, after cortex removal, bag is filled with OVD and a CTR is placed. The tip is guided under the capsular bag using a Sinskey hook, and it should be placed in such a way that the tip is directed towards the area of weakness so that further extension of dialysis is prevented. Now, the eyelet is released into the bag using a Sinskey hook. CTR gives equatorial support to the capsular bag. It also helps in centering the intraocular lens. Now, the capsule hooks are released. A 3-piece foldable intraocular lens is placed inside the bag. You should avoid violent rotation of the intraocular lens. Okay, the trailing haptic is placed against the area of dialysis so that this also gives support to the bag in that area. Now the side ports are hydrated to prevent AC shallowing and the forward movement of the lens. Now pilocarpine is injected to constrict the pupil and OVD was removed from above and behind the lens. Now intracameral moxifloxacin is injected and the side ports are hydrated. Thank you.
Thank you very much, Dr. Sandhya. It was not just a very good surgery shown, but you said exactly all the right things which need to be said when you're doing a surgery on a subluxated cataract, and the shallowing, not to have a shallow AC, and every step of the way, a perfectly done surgery. I would say that the only reason where in this 4 to 5 clock hour dialysis, you can get away with a CTR is because it was a traumatic cataract. But otherwise, if it is any other progressive zonulopathy, I think a CTS is indicated. Right, Dr. Minu? Dr.
Yeah,
Minu?
progressive means I think we should have 2 CTS at least to fix up both areas. But this just because it is a traumatic one. And I was also about to tell that this is like listening to a textbook description of how to do subluxated cataract. But I would like to differ in 2 or 3 areas as far as my personal thing is concerned. First, I would not change the location of my incision according to the area of xyle, because my comfort level is most important, because this is one of the most difficult cases I would do in fake. So my comfort level is very important, so I would not change. And pre-operatively, all the subluxated cases, I have started giving mannitol now, so that this keeping on vitreous, keeping on coming usually does not happen if you shrink the vitreous a little bit. And one point which was said was avoid nucleus rotation. So I would definitely, an easily rotating lens is more easily emulsified, but then trying to violently rotate and without a good hydrodissection and damaging more zonules is not a great idea. But if it's a good hydrodissection, I would definitely make tongue movements like this, left and right a little bit, so that it starts most. Initial rotation movement is more difficult to initiate. So small movements to either direction makes it mobile, and then after this bimanually. And then keeping the aspiration flow rate least is my main point during phaco. Aspiration flow rate being more will pull the visco which you have kept there to plug the rhexis area, and even the fluid which tends to go into the area of zonal dialysis and makes the vitreous hydrated, and it will finally, when you're aspirating cortex, we'll see that the PC gets bulged up and convex like this, just because 2 or 3 drops of BSS may go into the anterior vitreous and will bulge up the bag, and the bag will not open up for the later procedures. But a 3-piece lens in the bag is fine. Or the other option is to have a 3-piece lens in the sulcus and do a capture, which will help in some other ways also. The rexus has to be small enough and centered.
Yes, I also am not for the incision, and I also felt the capsule hooks need not have been placed so close to each other. Could have been kept a little more distant from each other. Although since it was a focal dialysis, just 2 capsule hooks were sufficient for you.
Madam, if you have a dialysis like this, it's always better to bunch the hooks towards the maximum area of in the center of the dialysis. Now, if you have placed 2 hooks towards the edges of the dialysis, you still have an area in between which is likely to flop. And although it is definitely a great idea to give mannitol, just because you have given mannitol does not mean that you can't. I think.
And besides, all our patients nowadays, longevity is more, and we have many high risk. I'm surprised if you have your anesthetist in the theaters, we realize how many of your patients are high risk and how many need definitely a physician consult before you take them for surgery. So mannitol should not be used as a routine because subluxations we do see more often than we expect. So I am not for giving mannitol because of the health issues. These have to be factored in.
We get witness. We get witness for everyone. There is no, as we think, no. Generally, there is a concept that cardiac should not give mannitol. That's all wrong concepts. There is no, just like that cardiac is not getting mannitol is not, there are definite contraindications for mannitol in definite cardiac situations. And so many people who have had stents and all those things, they are not patients whom
is not a contraindication at all.
Not
that is only the failures.
Patient with failure.
And overload. Yeah,
patient with
such
failure,
patients are not
low
not
ejection
many.
fraction. Those are the patients we have to.
And we do low ejection fraction and coming with subluxation. That combinations are not so very common. Then we should avoid. Definitely, we should avoid in that cases. But then
we can generally say that traumatic ones are more in younger people and who don't have any contraindication for mannitol.
But we get fitness.
Actually,
Definitely, madam, agree. We get fitness and then only do.
Actually, in this case, the pupil was round at the end and there was no peaking. Actually, it's a good idea to put triamcinolone at the end to see whether there is any vitreous is there or not.
Yes.
Because I didn't put because the pupil was round and there was no peaking. And also, I just want to have to know the opinion of the panelist. If there's a generalized zonulopathy like pseudo exfoliation, so what I usually do is I place the lens, 3-piece lens in the sulcus and do an optic capture and place a CTR inside the back, then do an optic capture.
Yeah.
So I want to know the opinion of panelists also on this.
Yeah, that definitely is a better, definitely the right way to go. But in severe zonular weakness, which was there, then you have, if you still want to conserve the bag, then you have to use 2 CTS. You need to attach it to the scleral wall. Optic capture, as you say, does bail you out from average zonulopathies.
Just to add on to the point Minu made about some fluid going under the capsule.
Yeah.
Quite often I have seen some small Rens fragments also.
Yeah.
You do this, you do this, you think you have done a great surgery. And at the end of it, you find that, anterior vitreous has a lot of these, small fragments. Obviously, they have gone in through the zonules with your osil fragmenting.
Even in regular cases, not zonal. Dr. Malukin got a grand prize for his video for documenting this with an anterior segment, intraoperative anterior segment OCT video. He got a grand prize for this.
So I think osil has, sort of making the nuclei,
And regarding subluxations, I would suggest that before anything, use triamcinolone as a first step. So if there is any occult vitreous prolapse, that will be overt and you will be on your guard. So first step of any subluxation, whether you see it or not, use triamcinolone at the beginning and wash it off, and then you can proceed with plugging and whatever.
It doesn't mean that the vitreous will not come in later. I mean,
absolutely,
anytime it can come.
Anyway, Sandhya, hats off to you. A very academic presentation.
Thank you.
Yeah. So we go on to our next speaker, Dr. Shivani Dixit, who is working as a cataract and glaucoma consultant and SRJ Netralia Indore. On to you, Dr. Shivani.
Good evening, everyone. Thank you, ma'am, for this opportunity. Am I audible and the screen is visible?
Yes. Yes, yes.
Hello all. I will be sharing a case of phacomorphic glaucoma and the challenges associated with it. Phacomorphic glaucoma is an acute secondary angle closure glaucoma precipitated by an intumescent cataractous lens by its larger size, both equatorially and anterior-posteriorly. Even though definitive management is surgical intervention in these cases, preoperative medical management is of utmost importance. It aims to reduce the intraocular inflammation and intraocular pressure, which will make the cornea clearer for surgical view. In this case, a 64-year-old gentleman who had diminution of vision in left eye since 2 years presented to us when he experienced severe pain in that eye since 2 days. On clinical examination, there was significant corneal edema, shallow anterior chamber, high IOP, intumescent cataract with mid-dilated pupil, suggestive of phacomorphic glaucoma. After starting this patient on topical steroid along with anti-glaucoma medications, the inflammation reduced, the intraocular pressure got controlled, and you can see that the cornea became clearer. Preoperative B scan was normal. The biometry report showed that anterior chamber depth is less, and there is a thicker lens of more than 5 millimeters. Moving on to the surgical management, there are many intraoperative challenges in such cases, starting with attaining a central adequate sized rhexis. We may encounter difficulties due to shallow anterior chamber, and also the possibility of weak zonules has to be kept in mind. Clear corneal side port incision with slow decompression of anterior chamber is done, and after general staining of the anterior capsule, anterior chamber is filled with dispersive, followed by cohesive OVD. Corneal main port with good architecture helps to get better chamber stability during surgery. Before initiating capsular rhexis, the intranenticular pressure is reduced by decompressing with a 26 gauge needle, and the liquefied cortical matter is aspirated. Capsular rhexis is performed using a capsular rhexis forceps. It is important not to let the anterior chamber get shallow and use cohesive OVDs as many times as needed. Here, I started with a smaller rhexis and then continued in a spiral manner to get an adequate sized central rhexis. After minimal hydrodissection, gentle rotation is done to ensure that the nucleus is free in the capsular bag. As you can see that in this case, patient had a hard leathery nucleus underneath intumescent cortex. In such cases, it's difficult to achieve direct shot. I am making a small crater in the nucleus first and then going deep into the substance to get a good hold of the nucleus, performing a horizontal chop to attempt divide the nucleus into two. Due to the leathery nature of the cataract, it gets difficult to get complete separation of the posterior plate. As you can see that I could get a partial chop here. After doing multiple chops of the heminuclei, I could take one nuclear piece out of the capsular bag for phacoemulsification. So after emulsifying one piece of nucleus, we get more space to work around and further nucleus management becomes easier. You can see that there is no residual cortical matter beneath to provide cushion to the posterior capsule. So I have slowed down my parameters while emulsifying these last pieces. This reduces our chances of surge. To add on to the challenges, while injecting IOL, it flipped into reverse position. However, it was flipped back and dialed into the bag. After thorough viscoelastic removal, the case was closed. Postoperatively, the patient did well with a good visual recovery and controlled intraocular pressure. Phacomorphic glaucoma is a preventable condition with timely cataract surgery, but when it happens, a meticulous pre-op medical management helps us get a better surgical outcome. Thank you for watching.
Thanks, Shivani. That was again a very good case. I think we've been having one after the other better and better batting. Excellent. I think this is a clear-cut case when we could think of giving
mannitol. Absolutely. I was about to say the same thing.
And another thing, these are cases probably where you could think of placing a trocar beforehand. So because little pars plana vitrectomy scope is there in these particular cases. That could also be factored in. And what else? Of course, intumescent cataract, she has discussed it very well and how she would do it. And
it would not be a bad idea to create some space with a bit of a trenching initially.
Yeah.
Just like you rightly said,
Yeah.
because sometimes when in these really hard cataracts with a leathery posterior plate, you
Yeah.
find that the amount of lateral separation that you need to do is so much that, the whole bag stretches, the capsule stretches. So if you can create some space there, maybe remove one small wedge of nucleus from somewhere, then the lateral movement gets much more easier. I think that is one point that I think.
Anything else?
The regarding that spiraling. See, there are in intumescent lenses, if it is leaking liquid cortex, it is okay. But then if it is the intumescent cortex, which is when you lift up the flap itself, you will see it's bulging up like this, convex. At that point of time, if we continue a rhexis and then move on to the periphery, then the mid-periphery again bulges up more. And I am not sure whether it will remain there or it may run away. So if it is bulging up in a convex configuration, I would complete it in a smaller size and then aspirate it off and then fill up the chamber and then continue after cutting the margin of the small rhexis which was created. And
very
yeah,
hard cataract.
Yeah, especially and hard cataract.
Axis extension at all. Yeah.
And as I was telling, the nucleus size, I always debulk the center. I make a large strand, go towards the center and debulk. And then when you notice, if you make the initial chop, if you make the chop, it may not go to the center. But then after that, you can go further deep into the already made chop cut and to take the chopper further deep into the chop which has been created, cleavage, and further split. So if you split like that, you need not split drastically till the sides, wide open splits. You can go further more into the split and make small openings so that you don't stress the bag too much.
You call it the multi-level chop.
Multi-level chop. Yeah.
Multi-level chop. I think that covers it. Anything about the post-op regimen in these eyes? We've got the nucleus out and the component of glaucoma bit. Any thoughts on that?
Glaucoma side?
No, I think she was asking Dr. Shivani.
Yes, ma'am. Ma'am, post-operatively, I feel that the first post-op day picture really gives us an idea as to how the IOP is going to behave. I usually, of course, considering the possibility of steroid response, I give more frequent steroids in the initial 1 week, along with topical AGM if the first post-op day IOP is still on the higher side. And then on subsequent follow-ups, we can taper the therapy.
Yes.
Can I add a point?
Yes.
In these intumescent cataracts, the bag will be very loose. So one option is to place the lens inside the bag before removing the last piece. So that will give a support for the bag. So this is very loose. So there is a chance of a capsule being aspirated into the aspiration port.
I saw in one or two of the cases the lens flipping. So see the haptic when it comes out, we have to keep on looking at the tip of the haptic. It should face towards your left always. So when the tip comes out itself, if it is turning to the other side, rotate your hand, and so that the haptic will turn towards the left always, and then turn on. And some haptics which are not the one which the Rainer model one, the straight open ones, sometimes they don't bend and they come straight outside and they bend backwards towards the right like that. So if it is tending to do like that, use your second instrument and fold it off when it comes out itself. You use it, hold it at the tip and push it, it will fold by itself and then you can release. So lens they don't just like that flip. It is our lax way of injecting that it lets it flip on a fast.
Anytime I think the second instrument is not being used properly to guide the lens. But the moment you feel that it's going to split, don't continue with the implantation. Use your second instrument too. So then you can avoid that entire flipping with two Sinskey hooks after the whole lens has gone in.
Now we'll have to go get a little faster because we have a number of speakers yet. And we thank you very much. We go on to our next speaker, Dr. Siddharth Kumar, who's a phaco-refractive and a retina surgeon from Kumar Eye Center, Patna. So on to you, Dr. Siddharth.
Good evening, everyone. And thank you, Chitra ma'am, for giving me this opportunity to present my case. Yeah. Is my screen visible?
Yes, yes.
Yeah,
yes.
is my
You can
screen
put it on
visible?
slides. Yeah, all good, sir.
So I'm managing a traumatic cataract. A patient is of 6 years old. He had a history of trauma by a stick injury, and the vision was in the left. Well, in the left eye was 1 meter is there, and the traumatic cataract was present. The capsule was ruptured, and the iris was the posterior synacle was present. We did the biometry, and we got the biometry in the left eye, and then we planned the surgery after a week, and we put the patient on topical medications and systemic steroids also. So here the surgery starts. As you can see, we are making a side port, and we are staining the anterior capsule with we are staining the capsule, and then we are putting a sodium halonate, and I'm releasing the synacle by the help of the spatula, and you can see over there. Now the capsular the nick has been made to make a capsular rhexis, and with the help of a microforceps, trying to make a capsular rhexis. As you can see over here, it has been run off a little bit, and then I'm giving a nick from the other side and trying to continue the capsular rhexis. This is how we have completed rhexis. I'm now making a main entry, and now I'm doing a little bit of hydrodissection. And as you can say, it's a very fluffy, and just with the help of the IA, we can aspirate all the fluffy cortical matters. And the care has been taken not to engage the bag or capsular margin. The parameters are quite low over here. So all the precaution will be taken care while removing all the cortical matters. Now, after removing all the cortical matters, I'm trying to engage as much as the cortical matter. And then now I am putting a 3-piece IOL. As you can see that it has been flipped. So just flip the lens in the AC, and then I'm putting it in the bag. After putting all the in the bag, now I'm washing off all the viscoelastic. And now the all the side ports and the main ports will be sutured, as it's a pediatric case, so it needs to be sutured because of the elasticity. Yeah, now the case has been closed. A little bit of hydro was done. And a tricot is given at the end of the incision to take care of all the post-op inflammation. So, okay. I think I'll just run.
Thank you. Thank
Yeah.
you very much.
Yeah. And this is the post-op picture. As you can see, after 2 weeks, the patient achieved 6/6 vision. Luckily, the trauma, the cornea was quite clear in the pupillary area, so the patient achieved 6/6 vision. Thank you so much for the patient hearing.
Very good case, Dr. Siddharth. Now, how do you plan? What was the age of this patient? I missed that.
6 years, ma'am.
6 years. So how do you plan your IOL power calculation? Like, how do you do it?
5% reduction in the IL power, which has whatever the calculation was coming. So 5% we have just reduced it for the myopic shift, because already the patient has almost achieving the age of 7, almost age of 7 to 8 years. So so we can just 10% reduction we have done it for that 5% reduction in that.
Something like a 7 minus age is a
Yes, ma'am.
way of going. And the
Yeah.
other thing is, did you do a hydro in this particular case? Did you do hydro?
Yes, ma'am.
You did. So I was just wondering, like in a traumatic cataract, unless you've done an ASOCT, theoretically, if you are not sure about the probable pre-existing PCR, whether you could even avoid doing a hydro in these cases. Would some of the expert panel agree on that?
I think hydro should be done very, very carefully. Without clear evidence of the intactness of the PC, hydro, if possible, should be avoided, because anyway these are very soft cataracts. And I think one more point that I would like to make is the timing of the procedure. So you need some gap to sort of get your IOL and everything ready. But at the same time, you should also consider the possibility of amblyopia. So you should balance between these two and do it off as early as possible. Some of these traumatic cataracts with a small opening in the anterior capsule, the cortex tends to get fluffy very fast. And so you shouldn't wait too long, and you should go ahead with your IOL procedure. Very good presentation, Dr. Siddha.
Very good.
Thank you so much, sir.
We are going to go on to our next speaker, Dr. Sucheta Parija, who is an additional professor and head of ophthalmology at All India Institute, AIMS Bhubaneswar. And she's going to show her case of complicated cataract. On to you, Dr. Sucheta.
Yeah, good evening, madam. Can you see my screen?
Yeah.
So,
It's a dark screen. Yeah, you will click. No, it will come on. Yeah.
so yeah, just before I start my case, just I want to say this is a 36-year-old male who is a myopic and presented to us with a chronic uveitis. So this patient was a HLA negative spondylar arthropathy and has been receiving steroid for a long time. So 3 months we followed up this patient before taking up the case, and we saw there was no AC flare or cells before we proceeded. So 1 week before, we did a preoperative thoroplasty examination, and we started the patient on steroid before we took up the case. The pupil was mid-dilated with multiple synechia. So what I did on the table is we started off, this thing is we did 2 side coats, and what I wanted to do is we wanted to do a synecholysis, take out all the synechia which is there. Sometimes these cases can have a broad synechia, and we have to be careful enough to remove it, or there can be epilenticular fibrosis which has to be taken out with a microforceps scissors. There is an alternative method. You can go and put under the iris multiple small bulks of this lignocaine or a BSS. But what happened, you can go about to do a pupilloplasty, but this we had done, but it did not stretch much. So we went ahead to put on the iris hooks in this cases. So I wanted to have a good capsular excess at least of 5 mm in this case. So better off you can use a atrata forceps, because sometimes you can have multiple fibrosis in the anterior capsule. But I went ahead and got a good rhexis with the cystitome in this case. So having an adequate capsular rhexis is a very important thing in this cases. After that, we did a minimum hydrodissections in this so that the nucleus is free and you can rotate it freely. So after that, we went ahead and I wanted to do a stop and chop or a direct chop, but this case had a inconsistent nucleus. What sometimes it was a little bit harder, and otherwise it's quite a soft cataract. So my aim was to do a gutter and flip it up like a flip and chop method, but still I was not getting it. So slowly what I was doing is I was trying to, with the low parameters, I was trying to take out or chop how much of the sections I can get so that I get a gutter. And what I wanted to do with take one end and flip it up. So this was not happening, and I was very slow with my maneuver because I didn't want any complications to arise at any point. So at each step, slowly moving about, taking a smaller piece, finally I was able to flip it up. So once I could flip it up, so this is how. Now I could flip it out, and once I have flipped it out, it was easier for me because there was not much of a thing. It was like a epinuclear bullous which came out. So I'm just stretching on this because sometimes we don't know how we get it. So be very careful what will be the PC at this positions. So after taking out or chopping out entire nucleus, you have to do a thorough cortical washup because no fibers we want to leave behind in uveitic cases, and do a good PC polishing. And here we put on a single piece hydrophobic acrylic inside the bag. So after this, we hydrated the wound, and there is a controversy whether you will be putting a suture because hypotony is something which has to be controlled. And this is the poster of day we had. The vision was quite good in these cases with 6-9. And what is important is we have to follow up these cases, and the regime of giving the prednisolone in this case has to be in a longer period, more than 6 weeks in these cases. And we used also diflupred in these cases and NSAIDs after for a prolonged period, and we are following up the case. Thank you.
Thank you. Thank you, Dr. Sucheta. A difficult case, but in a soft cataract, it sometimes makes sense to, I mean, it's very soft. You can just do a flip, or you can even do a stop and chop if you think you're not going to get your regular chops done, and you can get yourself out of that moment. And in these particular cases, flare, I think, is something which might stay even after 3 months because it's an indication for some vascular incompetence. So would you all want to start the patient on oral steroids in a clear-cut case of uveitis patient 2-3 days, unless there is more secondary causes? You know that the patient has a Behçet disease or some very significant uveitic case when you really need to keep them with the physician's opinion on the oral steroids and immunosuppressives. In a routine case, would you just start them on topical steroids a week before, or would you believe in starting them on oral steroids too?
I usually start only topical steroids. In straightforward cases, reasonably quiet eye, not much of inflammation. Post-op, you can always decide. This case, the post-op reaction was not much, but in some cases, you really do see a significant fibrinous reaction, a membrane forming across the pupil, sometimes a membrane on the surface of the IOL, which takes quite some time to break up. So intensive steroids, cycloplegics in the post-op period, very, very important.
Yes.
And along with that, if the reaction is very severe, we might even consider giving oral steroids.
Yes.
So I leave it to my uveitis consultant. So he actually gives it for quite little more number of patients who have had recurrent episodes, and then they have been on and off on steroids for some time. And one point during surgery was those fibrotic membranes in the pupillary margin. So if we nick it at the edge and then hold it and tangentially pull, they can be stripped off. If they can be stripped off very cleanly, sometimes it comes off fully, sometimes it may be in 2 or 3 pieces, but then it relieves the pupil of the binding down effect of the membrane, and you get a much dilated pupil with which we may not even need iris hooks or the expanding devices to be used for.
Thank you. We go on to our next case, Dr. Ravi Kumar, who's practicing a senior consultant at Anusuya Rao Eye Clinic at Vijayawada, and also in Nuzvid in Andhra Pradesh. On to you, Dr. Ravi Kumar.
Thank you, madam. Thank you for giving me this opportunity. Is it seen?
Yeah. Yes.
Iris dialysis is a surgical challenge managed by modified sewing machine technique and retrofixated iris claw IOL. This is a 60 years old male patient who presented with no improvement of vision even 1 month after cataract surgery. His best corrected visual acuity is 6/12 and N9 in the right eye. This is the slit lamp photograph showing a large iris dialysis extending from 7 o'clock to 11 o'clock position with no PC support and normal fundus. The challenge in this patient is to deal with aphakia without PC support and a large iris dialysis simultaneously in a single sitting. Iris dialysis is managed by our own innovative modified sewing machine technique published in Delhi Journal of Ophthalmology and Indian Journal of Ophthalmology. Coming to the management of aphakic component, since this patient is managed in a secondary level rural eye care sector where there are no retina services and lack of expertise in fluid SFIOL, we decided to do retrofixated iris claw IOL. Main steps of our surgical technique consist of retrograde threading of 10-0 proline suture into 26 gauge long needle, creation of scleral tunnel parallel to iris dialysis, pupil constriction by pilocarpine injection, creation of suture loops by passing the needle with the suture through peripheral iris and scleral tunnel from inside out. Cutting the loops and tying them so that the knots get buried into scleral tunnel. Finally, closure of conjunctiva using 10O nylon or Vicryl. The original technique is made easier by using a 30 gauge dental needle called Septoject. After creating the suture loops, the first end of the proline suture and tied to the last end so that only one knot is sufficient for entire surgery. This patient had iris dialysis and TR while undergoing cataract surgery and left aphakic. Iris dialysis was repaired using modified sewing machine technique followed by iris claw IOL implantation.
Yeah, thank you, madam, for giving me this opportunity.
Yeah, thank you. I missed out some things. One question to Dr. Debashish or Dr. Suven is there? Dr. Suven, he's there? Dr. Suven.
Yeah, I'm here. Yeah.
Do you have anything to comment on the iridodialysis part? Like, if there's a large iris repair, would you think there could be bunching of iris which would happen?
No, this is, I think, quite a well documented technique. Dr. Suhas Aldipurkar has shown this quite a few times, and I can see Dr. Ravi is also presented somewhere. So, because these are ultimately, each one is effectively an interrupted suture over there. So there is a gap between the sutures, and it's anchored at different points. So unlikely that it will get bunched up.
Madam, the point was that the tissue will get bunched up towards the angle, and you have a peaked pupil there, and the pupil will be peaked. And I nowadays do a pupilloplasty after doing this. It's a long-standing one. Sometimes the tissue shrinks, and when you take sometimes larger bites. But I would like to thank and congratulate Dr. Ravi for showing me this long back, and I've been doing this technique only for the last many years now. And that is this is the wonderful technique to use. And if the pupil is like that, I do a pupilloplasty also. And one more addition is that using a trocar and cannula, and put the cannula there to put the needle through. See, that prevents a lot of uncontrolled movements of the tip of the needle, which happens when you hold only at the outer part of the back end of the needle. If we pass it through a cannula, which is the trocar cannula, which we regularly use through the limbus, a lot of it is supported by the cannula, and the tip swaying movements at the tip can be minimized by taking the bites on the iris.
Yes, I learned from this procedure using the trocar. But the iris being the kind of tissue we know, this kind of a precarious situation where the iris root has been fixed up, putting a iris retrofixated lens, if you have somebody has put it in with his own hands, with that tucking in with that just repaired iris root, is really challenging. Well, at least it's challenging to me. Iris retrofixation of in this kind of a situation. I've never done it yet. I've seen it for the first time. Maybe I'll give it a try. But it's very
actually, the enclavation is done 90 degrees away. The dialysis was on the temporal side, and the enclavation was done at 12 o'clock and 6 o'clock. So where it was.
But it is going to put some stress on the iris root.
Yeah. And Madam, talking about the bunching of the iris, if you see the modified sewing machine technique, where we pass the loop with the one end of the suture into the loops, the amount of peaking will be reduced because the equitable distribution will be there through all the loops. So bunching at one point will be very much reduced. Just to want to add on that point.
See, even if there is bunching, and let's say there is a peripheral anti-assigning K formation also over there, let's assuming. I mean, it's about 3-4 o'clock hours. It really doesn't matter. The rest of it is open, so it doesn't really matter.
Yeah. Yes. Thank you very much. We go on to Dr. Zebint, who had to present earlier, but was caught in a flight. So he's going to be presenting his next case now. And Dr. Zebint is a high-volume young surgeon from the Arvind Eye Care Systems based at Coimbatore, and a wonderful surgeon. And he's going to be showing you one such situation. On to you, Dr. Zebint.
Good evening, ma'am. Thank you for this opportunity. This is a case of traumatic cataract with iridodialysis. After a 2.8 clear corneal incision is made, and after staining the capsule with trypan blue, scleral groove is made 1.5 mm away from the limbus, which corresponds to the scleral spur. And the AC is formed with high molecular weight OVD. The plan is to anchor the iris with a 10-0 prolin double arm suture. A 26 gauge needle is passed to the groove, and the needle is then passed to the peripheral part of the iris. I'm using a second instrument to give counter traction. It can be either a spatula or a micro forceps. Now the suture is threaded into the 26 gauge needle. And it should be threaded out, withdrawn out. Now the 26 gauge needle is passed 1.5 mm beside the first suture bite through the scleral groove. It penetrates the peripheral iris, and the second end of the double arm suture is docked and pulled out. Care to be taken not to involve the corneal tissue. Now both the ends are tied. Make sure it's not over tight. Aim for a reasonably round pupil. Now then the suture bites are buried into the groove. And as in this case, it's intralenticular pressure is more. So I'm planned to do a double rhexis. So initially a small rhexis is made to avoid Argentinian flag sign. Then the liquid cortex is removed. Then a small nick is made at the rim of the rhexis margin, and it's enlarged to the desired size. As multiple bout of hydrodissection is done and phacoemulsification is done. Initially, I planned for a direct chop technique because it's too soft. I'm not able to hold. Then I made a small trench and divided into two heminucleus. Then emulsified the cataract. And hydro is flushed to loosen the cortex. Then coaxial IA is done. With polishing. And a single piece IOL is placed inside the bag. The visco is washed in the anterior chamber and behind the IOL. And the conjunctiva is upmost. Thank you.
Thank you. Wonderful presentation. It is just that I'm just going to ask you one question. Because the cataract was so intumescent, could you have finished the cataract surgery and then done a iridodialysis repair? I mean,
Yes, ma'am. That's also an option, ma'am.
Yeah.
But I feel this little more comfortable than doing the cataract first.
I would retract. The problem will be that this will be a flappy iris tissue moving into the. That's what. We put an iris retractor hook through the cornea and then retract it and keep it there, because you really run a risk of touching the anterior capsule. You are a great skilled surgeon, very steady hands and all those. So, but it is not the same with everybody. So sometimes, if you tilt a little bit, the tip may touch the capsule and it may break there. So once the capsule is torn in the periphery, then you don't have a security of this rhexis which you have towards the end of the day. So I would definitely hold it with a hook and then do it later.
And it's an intumescent cataract. So I won't take a chance like that. Absolutely. Of course, you're a skilled surgeon, Dr. Jevin. There's no doubt about that.
Yeah. Yeah. Very good. So we go on to our next presentation. Yeah, thank you. Dr. Vipul Arora, who's a senior consultant in Vedanta Netralia, Ghaziabad, and he has another situation to show us. On to you, Dr. Vipul.
Good evening, everybody. Ma'am, I'm in Roorkee, Uttarakhand.
Oh, sorry.
Yeah.
So sorry.
Yeah, this case was referred to us for IL exchange, and the cataract surgery was done 1 week back. The IL implanted in this case was 18 diopters, whereas the intended IL to be placed was 23 diopters. So I am doing the IL exchange in this case. After putting a HPMC, main incision is extended slightly. internally more rather than externally, and using a dispersive viscoelastic to coat the endothelium. Because the main role in ion exchange is to safeguard the vitreous as well as the PC as well as the endothelium. With the help of dialer, the IOL is manipulated, and since surgery was done 1 week back, so it was not difficult to bring haptic into the anterior chamber. So I'm using a dumbbell dialer now to protect the posterior capsule and bringing slowly and gently into the anterior chamber above the iris, over the iris plane. And similarly, the second haptic. Now, under this IOL, the indented IOL of 23 diopters is implanted in the bag, taking care of protecting the endothelium. And viscoelastic is injected time and again, taking care not to overfill the chamber, but at the same time to protect the endothelium. Now, after this, the IOL is held with this IOL holding forceps. And thanks to Dr. Chitra ma'am for this initiative of this ARC, where I saw one of the doctor using this forceps. And so I bought one for myself. So this was really handy in case of IOL exchange. And with this, I'm using the Park Chang IOL cutter on an MST handle. And since the scissors are sharp enough and the IOL cuts in one go. Here I would like to mention this forceps actually hold the IOL very firmly. So after the IOL is cut, we have to use the second instrument to disengage this forceps from the optic of IOL. And after this, I'm using this forceps again to bring the two halves outside slowly and gradually, holding it from a little in the middle part of the optic, injecting viscoelastic again. And similarly, the second half is withdrawn. Here the incision is not more than 2.8. And the IOL explanted is checked for its completeness. And AC wash is given and wound is hydrated. And next day, the patient had 6/9 vision in this case. Thank you so much.
Thank you. That was again a very, very gracefully done surgery. Really nice. You showed very beautifully. It was shown how to use the right instrumentation. But just for the sake of discussion, in these early cases where the haptic is not fused to the capsule and all that, I mean, I would have also done your way, but I just wonder, does any of you would like to get the haptic out, one haptic out out of the incision and then go on to cut, or would you all do it exactly the way he's done? Any of you on the expert?
I would do the same way as he did, because when I get the one haptic out, the part of the optic also comes very close to the incision. So it tends to crowd there and it tends to touch on the endothelium. Very difficult for me. But I would do, this is a perfect, fantastically shown and very gracefully, elegantly shown. Congratulations. Only thing is, I want to know, where did you buy that forceps?
From Epsilon.
Epsilon. Very good. Thank you. And only thing is, one more point is that...
Both the forceps and the scissor?
No, other one, scissor cutter.
No, yes, both from Epsilon. And I would like to thank again Chitra ma'am, because I have seen this case, some other surgeon doing it on ARC platform itself.
Yeah.
And one more point is to inject viscoelastic, because it is fresh, it is fine. But
Yeah.
viscoelastic into the bag also will be a good idea.
Yeah, actually, it's
To
an edited
expand
video.
the bag
It's a
before.
little edited video, but it was.
Yeah.
I have.
Just to mention that for a long term.
Yeah.
Would anyone use a Sulcoflex piggyback in such situations, or all of you would go ahead and
I
remove
think
that? If it was a year, it was
if it's an
sometime
old case,
later.
if it is
6
an
months.
old case, you can think of placing a Sulcoflex piggy bag IOL, which is a very good option. But in a fresh case as this, I think all of us would consider doing an IOL exchange only.
I recently used this piggy bag in one of the cases of RK incision and 6-year-old IOL case done. And the IOL I used was of IOCare. So they customized it for me, and it was not at all pricey. It was
actually Sulcoflex is very costly also.
Can I ask one doubt?
Yes, Dr.
Rainer.
Sandhya.
Yeah. In case of this looped haptics, that won't come out so easily like this. In such cases, how do you remove it? You cut the optic and remove the optic alone, leave the haptic in the bag, or you just cut the looped haptic also and then take it out?
1 week, all IOLs will come out.
Yeah.
1
No,
week,
not
1 month.
Because it's slightly longer duration, then this looped won't come out so easily.
Then you leave the haptic, cut the haptic, leave it in
Cut the haptic and just take out the optic.
Yeah.
Can I add something?
Yeah.
This cutting of the IOL is a very nice technique, but recently I've shifted to twist and out technique, especially for single piece, where you hold the IOL through main piece, main port, and support endothelium with the spatula and twist your hand. IOL gets rotated and then it comes out through 2.8. You don't need to juggle and cut it.
A hydrophilic lens or a hydrophobic lens?
Hydrophobics are very easy, since hydrophilic are thicker than hydrophobic. Are a bit difficult to come out through the same incision.
I have also seen this, but it seems a little scary to just do it, and endothelium injury might be a possibility.
Yeah, initially, but once you get on with it, it's a very easy technique rather than cutting. And I've done almost 7 to 8 cases, and it has popularized by Dr. If I remember his name correctly, Dr. Uday. Yeah, he popularized it, but somebody else has, his name is Dr. Pant, it seems, if I correct it rightly. So you need a practice, definitely, but it's once you get a hang of it, it's definitely easier than cutting the IOL.
Thank you. Thank you very much. We go on to our next presenter, Dr. Bhagyashree Deshmukh, who's a cataract refractive surgeon from Deshmukh Eye Hospital, Amravati, and she's going to show her interesting case.
Good evening, everyone. Thank you all for having me here, especially Chitra ma'am. I'll just share my video. I hope everybody can see the video. Shall I start?
Yeah, you're just, it's showing screen sharing.
We can't see the video.
Yeah, it will go on now. I'm sharing a rather unusual case of teleportation of nucleus piece into the vitreous. Why do I use this funny term teleportation? Because those who have grown up with Star Trek must be aware of the phase Bimini Scotty, where the characters used to get teleported from one universe to another. So to begin with, this is a pretty usual case. Nothing.
We still can't see your video.
Still, we can't see anything. It is not showing.
You can't see.
You stop sharing and share again once.
Okay, I'll try that.
Sharing, open the presentation and then share.
Okay, give me a second. But it started okay, right? Initially, it was showing.
No, it was always black.
It was always black. Okay. Okay. Yeah. Now can somebody give me feedback? Can you see?
No, not yet.
Still coming, doctor.
I think there is some network issue.
Doctor, you can stop and
No, it's
reshare.
not network issue because sharing is showing. but then the video part is not seen.
Let's just stop
Black
and
screen.
reshare. You should be able to do it.
We'll try it once, otherwise we'll have to.
Yeah.
Now you'll get it.
I hope, I really hope. Now it's coming for over my screen, madam. Can you all see?
Yes, we can see this. See the.
Ma'am, we can only see the folder. Just stop share for a minute, doctor.
You can
First,
see.
no, just stop share, doctor, once. Doctor, first open the video, pause it, then do the reshare.
I'm trying. I'm doing the same thing.
Just keep the video paused, then do the share.
Yeah, the video is open.
And now you can share.
Sunil, if she's not able to show it,
Maybe the next speaker can speak and I can come back.
No, Mr. Sunil can show your video.
Yes, ma'am. Yes, ma'am.
Yeah. So
it has a voice in it. I would like to speak for myself. So if he can
the voice, he'll mute it. He'll mute the voice.
Yeah.
Mr. Sunil, you show it.
Just a second.
Yeah.
I'm not able to trace a video, ma'am.
Oh, how's that? You have to be very careful about checking it, Mr. Sunil.
Ma'am, the dumb.
I wonder why is this happening, because I can easily share it and I can easily see my own video.
No.
Let's try now, ma'am. Last time, or we'll just figure it out in next.
If it's not happening, then you can log off and log in back again and show when the next person starts.
Call her on phone and try help her. In
Yes,
the
ma'am.
interim, we go on to Dr. Manoj Pratapan's case. We call on Dr. Manoj. Her video is actually very nice, good discussion video it is. So I do want us all to see it. We shall now go on to Dr. Manoj Pratapan, who's a Associate Professor of Ophthalmology from the Amrita Hospital, Kochi, and is also a glaucoma consultant. And he's going to show us a very good glaucoma surgery video, which is step-by-step explanation. Dr. Bhagishri, you should stop sharing.
Yeah. You even now you cannot see, right?
No, we can't see. Mr. Sunil has to guide you through it. We would wait to see your video, but in the interim, you stop sharing so that, yes.
Good evening, everyone.
Yeah.
I hope my audio is clear.
Yes.
Okay. So this is a very interesting case of a 65-year-old lady who is having type 2 respiratory failure, needing ICU care. She was admitted in elsewhere hospital, developed acute angle closure glaucoma about 7 days back, and then was referred here. She was given topical and systemic anti-glaucoma medication, but not pilocarpine because of unavailability. So when the patient came to us, patient's right eye vision was 1/60 with the pressures of 62, closed angles and with significant corneal edema. The other eye was just primary angle closure suspect. We tried giving her systemic and topical anti-glaucoma medications, and the corneal edema never subsided, so she was not responsive to pilocarpine. I was able to manage a laser peripheral iridotomy through the edematous cornea, and temporarily it worked. There was a drop in pressure to 30 millimeters with clearing up of cornea and an improvement in the vision. But at that point of time, I was able to see that the 360 degrees gonioscopy showed peripheral anterior synechias. Again, the patient returned after 3 days with again diminution of vision. The pressure again went up to 56 and the cornea was again steamy and vision dropped down to 1/60. This patient was still in the ICU at that point of time. So we couldn't wait too long with these high pressures, and I decided to go ahead with trabeculectomy with phacoemulsification for this patient. In the OT, I had given IV mannitol and the peribulbar block for this patient. And while the patient was being draped, she was very uncooperative for further proceeding. She was very anxious, her BP increased, and The saturation was maintained, but her pulse rate and BP was high. So considering that she was already in type 2 failure, I didn't want to risk a cardiac event. So I called off the surgery at that particular point of time. Thank God I did not start the surgery at this time. I discussed with the patient's bystanders about the problems, and then later we decided to go ahead with the sedation. So I discussed with the general anesthetist. They said that if the patient requires intubation, that means that patient could end up with a ventilator support, and maybe we won't be able to wean the patient out of the ventilator. So again, the patient was very keen on proceeding with the surgery. Conservative management was not acceptable to her. So considering the risk, we have proceeded with the surgery under sedation. So let us look at the surgery. Patient is already prepped with IV mannitol and AIOS. The cornea is still edematous, but the pupils did dilate well.
To reduce the risk of conjunctival hemorrhage, the eye is preoperatively prepped with topical steroids. After using mitomycin C, 4x4 mm triangular scleral flap is created. In vivo shallow AC, care is taken during first side port insertion to avoid injury to the iris and anterior capsule. In the absence of corneal haze, it is better to use tryptophan blue dye for better visualization of anterior capsule. The second side port and main port are created now with adequate viscoelastic cover in the anterior chamber. Capsular access is not very challenging, but make sure the cystosome needle is more bent to compensate for the shallow anterior chamber. Also, if need be, better to refill anterior chamber multiple times during the rhexis or use a cohesive viscoelastic. Doing incisional surgery in a patient with acute glaucoma runs the risk of having expulsive choroidal hemorrhage and aqueous misdirection syndrome. Always take up the patient under very guarded visual prognosis, as there is higher risk of surgical complications and optic atrophy due to such high intraocular pressure. After adequate hydrodissection, phacoemulsification is carried out. Phacoemulsification by itself is not a big challenge here, but the cornea is hazy, so the visualization is poor. A slow emulsification would be ideal here so as to prevent collateral damage by inadvertent injuries. Pupillary dilatation is not a bother in most of these cases, as acute IOP does not affect the dilated pupillary muscles. Iris injury near the main port by the phacoprobe can be reduced by deepening the anterior chamber with good amount of viscoelastic substances prior to the probe entry. A modified direct chop is used to manage the nucleus. If need be, refill the anterior chamber multiple times with viscoelastic so as to reduce collateral damage to the iris and capsule. A conventional bimanual irrigation aspiration of the residual cortex system. Cornea at this stage is still hazy. One can appreciate the glare from the reflections of the cannulas. A foldable hydrophobic acrylic IOL is implanted into the capsular bag. The trabeculectomy wound is entered with the help of a keratome. Kelly sponge is used to make the ostium at the angle. This is a 0.75 mm scleral ostium with more than 1.5 mm of scleral cover on both sides. A broad-based surgical iridectomy is done. The scleral flaps are closed with tenon-iron sutures. The apical suture is the appositional suture. These sutures are not meant to be tight. Pilocarpine is injected into the anterior chamber to construct the pupil. The side walls of the scleral flap are closed by two radial sutures. These are the compression sutures. The tension on these are important for filtration. It is preferable to err towards tighter scleral flap sutures with the releasable suture. It is better to avoid overfiltration and hypotony in these patients who have acute glaucoma. Early postoperative period, a transient hypertensive phase is preferable over a hypertensive phase. Since there was pupillary peaking at 12 o'clock, an iris repositor is used to pull the peripheral iris strands away from the ostium. Residual viscoelastic is thoroughly washed with help of zinc irrigation aspiration cannula. Corneal wounds are hydrated and the scleral bed is tested for excessive leaks. If need be, the suture tension can be adjusted at this stage. An excessive leaky wound can be optimized by tightening those releasable sutures. If we want to increase the drainage, then gently rock the sutures sideways to ease the tension on the releasable sutures. A combination of radial and box sutures are used to close the conjunctival wound. This patient at the end of 1 month has achieved a visual acuity of 6/9 and an intraocular pressure of 13 millimeters of mercury. Thank you for your patient listening.
Lovely surgery. I mean, I truly enjoyed watching every step of it, and very meticulously done surgery and beautifully explained. I honestly don't even have questions here because it was a very good teaching video which you showed us today. Very nice.
Thank you, ma'am.
Can I give one? Can I add one point?
Yes.
When you have epithelial edema and haze like this, one trick is to use a wet cotton spud, wet, and then tightly roll it over the cornea. You will see it instantaneously clearing, momentarily, not momentarily, for a few minutes. So that is one way to clear up the steamy corneas intraoperatively.
And I would have probably used pilocarpine a bit more earlier, so that my iridectomy is more basal.
Actually, we have a big shortage of pilocarpine. Even carpinol, which we inject into the antichamber, was also not available for a long period of time. So in the back of my mind, I was thinking that pilocarpine was not available. Then I saw that small peak. Then I asked for the pilocarpine, it was available. Then I used it.
Yeah. Yes. Very well done.
Good.
Well,
Good.
very good. I think every tip he said is so very relevant. Very good video. Do you think you're ready, Dr. Bhagishri? Oh, wow. This is why I have to always thank Mr. Sunil. Thank you, Mr. Sunil.
Of teleportation of nucleus piece into the vitreous cavity. Those who have grown with Star Trek must be aware the catchphrase "Beam me up, Scotty," and the character used to get teleported on a different universe. It was a pretty usual case. Many of us do this at the spinal level. Everything was going well. I had a good rhexis, nothing untoward happened during phacoemulsification to engage any gray cells. And suddenly, during cortical aspiration, we see a small nucleus piece in vitreous cavity. Spinal reflexes fade away and gray cells start firing. So my first reaction is that there is posterior capsular rent which I missed and I have to go and find it. So I start injecting visco all over PC, tried to push, prod and poke the PC to find a rent. But posterior capsule was intact. So next logical conclusion is that there might be some zonulopathy, some opening in the zonule somewhere which allowed nucleus piece to sneak out in the anterior vitreous. So I insert a capsular tension ring to buttress the zonular opening if there is any. So now I have a situation where there is an intact posterior capsule and a nucleus piece in the vitreous. So I have two options to manage. One, to do pars plana vitrectomy and remove the nucleus. And second, to perform a posterior capsulorhexis and do anterior vitrectomy. We chose second option since it is a topical case and nucleus piece is just behind the posterior capsule, thankfully not drop further into the vitreous yet. I do a thorough anterior vitrectomy, separating the nucleus piece from the vitreous attachment, and I slowly lifted it in the anterior chamber. Then the nucleus piece is visco delivered through the main port. Taking care not to let the anterior chamber collapse by continuously injecting visco while taking out the piece. I implant a single piece lens in the back. It's a good idea to support the lens with second instrument if your posterior capsule is not intact. Checking for vitreous strands in the anterior chamber with the help of triamcinolone, and the case is closed. Patient had excellent vision on the first post-op day. Now I put my thinking hat and ask myself, how and why did this happen? Previously we had noted a small cortical piece sneaking behind in similar fashion. It did not need any intervention because it was a small cortical piece. But this time we had this big, almost 2 to 3 millimeter of nuclear piece sneaking behind. And of course, nuclear piece did not teleport itself. And retrospectively, when we thought, there were absolutely no signs of zonulopathy. There was no wrinkles on anterior capsule while doing anterior capsulorhexis. There was no movement of anterior capsular rim. So it was unlikely that we missed zonulopathy. My phaco settings were normal, not very aggressive. So the last explanation could be that there might be some anatomical variation, some breach in the continuity of the zonules that could have led to this unusual complication. But I am still thinking. Thank you very much.
Thank you very much, but wonderful video, wonderfully discussed. But I think we cannot, I don't think there's zonular weakness because your rhexis was round. You know, if there is a zonular weakness, the rhexis will not look so round. I think it could be a peripheral PCR, a very small peripheral PCR where the vitreous had not come forward or anything. And with an anterior hyaloid face through which the piece could have gone behind. And I wouldn't know if at all it's a peripheral PCR, you know, by doing a PCC, was it right? In the end, in your case, it went off very well. You unmute yourself. You are talking, we can't hear you.
I ruled out all the things step by step.
No,
Definitely
you did
there was no
the central peripheral PCR, I mean, under the iris, where you have not, you didn't retract the iris or look in that direction. Could that have been the reason why it went, instead of putting it to abnormal zonules? Anybody else has
had it been there, the peripheral PCR, while I injected the PC, while I did the PCC posterior capsulorhexis, I would have seen that. I would have found it out.
Unless you retract the iris, you would not see it.
A peripheral PCR would definitely extend when you put in a CTR, madam.
I will like to agree with Dr. Bhagyashi's logic. We do see these small fragments, and I think Sai mentioned some time back about these.
Yeah.
Yes, so we do see these, and Dr. Chitra, we need not necessarily see ovalization of the capsulorhexis, because these zonules, I mean, the gaps, with the pressure, these small fragments can sneak in through the zonules, and there could be a zonular defect over there, and it can still sneak in and not cause any further damage. So I think that is quite a plausible explanation.
Could be possible through the zonules. It is true.
I've also had that. I've also had this. So I mean,
this big I've never had. This bigger piece, maybe it is because it is thin and elongated. Could be in that direction, could go. But one point which I wanted to make is when you open a PC, I would not inject HPMC. I would inject either viscot or sodium hyaluronate, which can be easily taken out, and if left behind, would not react with the vitreous as violently as HPMC.
There are two sides to that. If you leave behind HPMC, it will get absorbed. Maximum will cause rise of IOP for 24 to 48 hours. If you leave behind any higher molecular weight,
that would cause a longer time.
Bigger pain for a longer time. Okay.
No. It gets inflamed. It doesn't get absorbed that fast because it is stuck behind the capsule and the IOL which is stuck there. It will not let it come out, and it will mix with the vitreous more.
Yeah, she's doing
and it will stay on for a longer time.
See, she's doing a vitrectomy after that. So she's doing a vitrectomy. That's not going to leave any vitreous behind. And if you
after that, I think I saw the point is general point is I'm not criticizing this or anything, but I saw visco being injected and then the IOL being placed. So HPMC is known to be and published that it causes more inflammation and IOP rise. Inflammation is the more important factor.
Because many of these cases, when you have a very small PC rent while trying to polish the capsule and all, you just maintain the chamber with sodium hyaluronate, and you don't bother to go under the IOL to remove it. And most of the eyes are very, very quiet, unlike the HPMC. I think I will agree with Minu on that. And Dr. Bhageshwari, just one more question. What was the instrument that you used to do that PCCC?
It's a capsular access forceps.
It's a microcapsular forceps.
Okay, and one more thing, it's not a nuclear fragment actually. It was not a nuclear fragment, it was more of an epinuclear fragment. When you did the vitrectomy, it was pretty clear. It was not a nuclear fragment, it was an epinuclear fragment. And that's why it kind of sneaked in.
It was pretty hard to be a epinuclear because it did not get with the vitrector. I was even tried cutting the nucleus, the piece itself with the vitrector. It was pretty hard. So in my opinion, it was a nuclear fragment.
Okay.
Do I have anyone in my school living it just like that in that place in situ?
I said that previously we even had a small cortical fragments. We left it.
Just left it like that. Nothing would have happened. Maybe
it was pretty big piece for me to leave behind.
I think Minu, Sai, and me and Dr. Chitra are from a generation where we have seen half full 3/4 nucleuses left behind in the vitreous. What do you say, Dr. Chitra?
Yes. Small epinucleus would
so
not
these
have
younger people would have seen so many nuclear pieces.
Even the shape of this one also made me think that it is epinucleus rather than nucleus.
Same here.
Elongated and all those. But she had the direct look through the microscope. She should be able to.
She felt it with the vitreous cutters.
Yeah. It was nuclear. I think we've extended our time by half an hour, but I'm sure our expert panel would agree with me that we saw such a fantastic variety of cases today. It was so very nice and very well presented, and lot of commitment. And just as much as I learned, or Dr. Vipul said he learned, I'm sure many of those in the audience would have learned a lot today. And thank you so much, expert panel, for continuously steering the webinar along with my moderating questions so that we got all the right answers for all the questions. Thank you so much. Thanks so much. A wonderful set of speakers. And each of you, I don't know, it appeared as if you all had talked to each other. We had one IOL exchange, one iridodialysis, one zonular repair. Every kind of situation was discussed. So thanks so much. It is truly a wonderful webinar. I definitely would start by saying, of course, I really have to thank Satyajit for not budging a moment from that place. It was constantly there, It's like me getting positive energy from one direction that I'm there for you if you have to even get up and go for a minute. So thanks so much, Satyajit, for being there. Thanks so much, Mr. Sunil, for the constancy with which you helped me all through these webinars. Thanks so much. Thanks to Kripal and the AIOS admin for all their support. Thanks to Sai and Manjula from Numerotech for their support. I need to actually tell you all that I have one guy, Velmurugan, who's constantly, creating these flyers and constantly asking for your intros and giving so much help to me. And it's something I never ever mentioned. The first time I'm mentioning the kind of help I have that one guy helping me for all my ARC work. So I definitely need to thank him and ask him to watch what I commented on him. And finally, and most importantly, we have to thank Entode for sponsoring all these webinars of ours. And I'm sure all of us are learning continuously from it. And thank you, dear audience, for being there. I'm sure Mr. Sunil will tell us the numbers at the end of it. And that is the biggest energy for us to keep coming back and sitting for a long time after a hectic day to have these webinars happening. Thank you. Thank you very, very much. Thank you.
Thanks to you for all the energy, all the enthusiasm.